the hospitality and everything. My talk is about corneal opacity, how to approach. It's a very long talk, so I'm trying to go very fast in this subject. Let's start the presentation, please. Okay, when we start about the corneal opacity, you have to take a very good history from the patient. You have to proper clinically assess the visual acuity and refraction. You have to spend time in the slit lamp examination, examining every part from the epithelium to the endothelium, and you have to do some corneal laboratory tests like scraping if cornea infections. And you have to do corneal imaging, of course. The role of anterior segment is OCT in the corneal opacity is a must. Maybe then you have to, when you have, after you finish all this, you have to decide either a surgical or non-surgical treatment. Surgical treatment, either urgent or selective. Urgent in case of perforation and infections, like we do hot keratoplasty or amniotic membrane, and urgent in children before the age of 12 years. In selective, either non-invasive like the laser or PCK or EDTA or in keratoplasty, and this depends upon the depth of the opacity. Either we do a full thickness graft or lamellar graft. Non-surgical, sometimes the medications and the contact lens. And there is certain prognostic factors you should keep in consideration, like the ocular and adnexal, the vascularization, the tear film, the associated comorbidity. Maybe I'm going to present a lot of cases in my presentation in order to it. This is a child sent to me for keratoplasty. As you see here, he has a bilateral faint opacity. And of course, this child, not for keratoplasty, has a band keratopathy complicated to recurrent uveitis. As we see here, and he has a cataract on the same time in the right eye. And this is anterior segment OCT. And the plan here is to do EDTA. I did EDTA, and then I did a cataract in the right eye and EDTA only in the left eye. The second case is the granular dystrophy. And of course, you have to do the anterior segment OCT to see the depth. And this treated by a PTK also, and this is a post-op. Sometimes you find the residual, it's okay, as long as the vision is good in this patient, and this vision here, it was 0.8. This is a pseudophakic corneal opacity, as we see here in the photo. This is a 70-year-old. He did a cataract, and he has this opacity. And of course, this is epithelial map dot dystrophy, as we see here in both eyes. And the patient didn't know the drop of vision from the endothelial or from the epithelium. As we see here, is purely from the epithelium. And of course, doing specular microscopy in such patient, you can't do it because of the corneal opacity. As we see here, the anterior segment OCT showing the depth of the opacity, and in both eyes, and it was treated by PTK. And always postpone the correction of refraction error in such patient after treating the PTK. In this case, you have to remove the epithelium manually, not by laser, because it's adherent to the underlying. And this is the post-op of the patient. The case 4, sorry if I'm going so fast because I have a lot of cases, I want to present it all. This is a 90-year-old patient. I did for him a PRK, and on the 5th day he got infection. As we see here, an ulcer, infected ulcer, and here this is an emergency, you have to treat it, and after giving him all the medical treatment, he has this residual opacity, as we see here on the last photo on down on the left, and the vision is here. We have to stop after 9 months. His best corrected visual acuity is 0.9. So don't treat this opacity as long as the vision is good and it's not in the central axis. As we see here, this is the anterior segment OCT of the patient, and this case 5, this is a very interesting patient. She sent to me for keratoplasty. As we see here, she gave a history of LASIK, and this is the epithelial engross. Although that the right eye is a good seeing eye, the vision, she see 0.8, but she's not coming for the poor vision. She came because she hated herself that she had this white lesion. And after doing anterior segment OCT, and as we see a close-up view of the photo, she had this white opacity, and of course you have to raise the flap and remove it. But the patient refused to do the surgery. She preferred that she is better to leave her, and she's treated by a contact lens. And I give her a contact lens, and she was very happy to put the contact lens and to hide this opacity. The case 6, this is my case. Always I got touched by this case. This is referred to me, and she had a bilateral corneal infection, as we see. She is a keratoconus patient, and she put a contact lens for the keratoconus. And she kept years, 2 months, staying in the dark. As we see here, the anterior segment OCT in both eyes. And this, can you put on the video, please? ممكن تشغل الفيديو؟ لا حضرتك ارجع. As we see here, this is really a tough case because you are planning to do a penetrating keratoplasty. Always in such cases, you have to start doing a lamellar. And as we dissect, we know the depth of the lesion. As we see here, removal of the superficial part, and you are working under a lot of blood because a deep vascularization. Here, continue your dissection as you remove a lot of superficial lamellae to reach the deeper lamellary. You have to be calm and take your time and don't hurry in order to remove. Always in such case, you work under a complete deep vascularization. So you have to be very cautious in each layer you are removed. Here I'm dissecting the deeper. As we see here, all the infected area, it's removed. So I'm trying to find my plane to reach the deeper plane and put my graft. As we see here at the end, I found a deep septic focus at the back of the endothelium. At that moment, I asked myself, do I have to convert to penetrating keratoplasty or continue my lamellar dissection? And I said I will continue. And during doing the last step, I got a perforation. And I think that God take the decision in such case. I have a perforation, so no options. I will convert to a penetrating keratoplasty. Can you move? Okay. For the sake of time, and this is the first week of the patient, okay? And this is the other eye. I did the other eye 1 week apart, and the same step I follow. ممكن نسرع الفيديو شوية لو سمحت؟ Here I decide also to start the deeper dissection and to do a lamellar keratoplasty. ممكن نسرع أكتر شوية؟ As we see here, we have a central area. This is not the descent. This is a deep lamella. Can you see here? I'm trying to find my plane in order to reach also the deeper plane. Can you see the deep vascularization that the patient got it? Severe vascularization. And finally, I found my way. And when you find the bleeding, you have to stop. Don't push. Just put your sponge and the bleeding will stop. ممكن نجيب اخر نسرع شويه الفيديو لو سمحت. And then I reach my final plan. As we see here, this eye is different than the other eye Because when I reached the deeper plan, I didn't find the septic focus at the other eye. ممكن نسرع شوية? Yes, and this is the bed at the end. I put my graft, and here how I peel the descent membrane. Sometimes use one graft for 2 patients. But in this case, I get rid of the descent because it's infected, and I put my graft. And this is the post-op. On the first day post-op, I got a surprise. I did an OCT, anterior segment OCT, and found a descent detachment. Although I was very happy that I did the DALC, but the patient got a descent detachment. In such case, don't be surprised. In cases with corneal infection, we face this. And what to do? Do I have to stop or enter and re-bubble? I decide to stop, and surprising, there is a spontaneous reattachment of the descent without any intervention. Here, the poor adhesion because there is inflammatory cell between the stroma and the rest of the descent. Okay, and this is the post-operative. And very important to follow the epithelium because the epithelium takes time to heal. And I use in this step the insulin eye drop, which giving amazing result in the healing of the epithelium, and sometimes the autologous serum. And this is the post-op, and this is the final. I'm going to the case 7, and this is another lady. She came with history of cross-linking. I did for her the DALC, and this is the post-operative. As we see, sometimes we find a loose suture. You have to remove the suture immediately and don't wait. Okay, and then I did for her the cataract and put a toric IOL. And this is the post-operative. Again, this is another lady, young girl, with a corneal infection, all this from a contact lens. In this case, I start to decide to give her a medical treatment, a fortified eye drops. As we see here, she got improved without any surgical intervention, and this is the post-treatment. Case 9, this is a lady, she was pregnant lady, and she got a corneal infection, and she's been treated elsewhere with medical treatment. I gave her another 2 weeks of medical treatment. She didn't improve. I decided to do for her the surgery, and as we see here again, this is a DALC, and the descent is detached. Don't wait, just give 2 or 3 days and it will attach spontaneously. And this is the post-operative, and she was very happy that this is the end result. Case 9, this is a pregnant lady, and she got a corneal abscess. Can you see the anterior segment OCC? There is membrane inside. So I expect intraoperative that it won't go DALC, and of course I did for her a penetrating keratoplasty, and the post-operative on the left, there is a residual opacity. Leave her and don't do her until a year after the operation. So case 9, this is a corneal infection with a perforation, corneal abscess with corneal perforation, and this is the video. Can you put on the video, please? As we see here, we saw this is a lost eye, but actually after the surgery, ممكن نمشي بسرعة شوية للآخر كمان. Okay, yes, كمان. And this is, as we see here, كمان, I'm trying to find any plane. This is the, when I see this patient, I said it's a lost eye, and I told the patient I will do for you the keratoplasty, maybe you will improve. For the sake of time, I'm sorry, and this is the first day post-operative, and this is a 10 days post-operative. Actually, the patient is very happy. And this is a case with a corneal melting, as we see. I put all the graft in such a patient. ممكن نجيب آخر الفيديو? This is a manual, yes, more. آخره خالص. Okay, and here, you have to remove all the infected tissue and send it to the pathology before completing your surgery. And this, the lady, this is a pre, and this is the first day post-operative, and this is the second day post-operative. The case, this is a case, a child with a congenital endothelial dystrophy, and this is a paper I did with my dear friend, my dear colleague, Dr. Hazim Yassin. We did this that we do remove the endothelium with the femto and put an ultra thin DSAC. Can we put on the video, please? And we start this paper on 218 and ممكن نشغل الفيديو؟ And till now we have a patient for لا حضرتك ارجع شغل الفيديو ده put هنا As we see here, we cut with the femto, and after we cut with the femto, we do separation of the posterior lamellae and remove this from the posterior lamellae, and then you introduce your ultra thin DSAC. It's a very simple and easy procedure after you put it, and we have patients till 8 years follow-up have the graft clear, and this is the end of the surgery. And this is another case, corneal edema due to anterior chamber phakic IOL. Here, when you remove the epithelium, the visualization will clear. As we see here, we add difficulty to the operation that you have to remove the phakic anterior chamber intraocular lens in order to do your DMAC surgery. ممكن نمشي قدام شوية الآخر خالص. Okay, here we remove the cataract and then we put the DMAC tissue. آخر الفيديو. I'm sorry because I'm running fast because 10 minutes. And then we do and implanted the DMAC tissue. ممكن السلايد اللي بعده؟ Case 14, this is a very interesting case. Patient with history of bee sting injury while working. As we see here, he has an infected ulcer. As we see here, always when you're trying to remove this in the OR, don't try to take it from the cornea. You have to remove it to push it, not to pull it from the anterior chamber. As we see here, this is the anterior segment OCT is a must. Okay, as we see here, it's inter. And when I did endothelial count to this guy, he has a lost endothelial gut. But wait, treat. After removal of this part, he has this residual opacity. As we see, 2 months, 3 months, and the vision got 0.7. And this is after 2 years follow-up. He came to me a month ago with this refraction, and he's happy. In such a case, don't treat this opacity. Leave this patient with this refraction and don't do anything for him. Maybe this is a case of bilateral corneal opacity in a young girl, 21, and this is a post-trachomatis or post-spring catarrh, and this is the anterior segment OCT and the pentacam. As we see here, she had a thin cornea. Please, give her a medical treatment, although she's seeing 0.8 or 0.7, don't touch this opacity. And this is a child, he got injury, he has an ulcer. As we see here, before dilatation, after dilatation. Before dilatation, it was plus 16. After dilatation, plus 2.5 with minus 375 astigmatism. This is the pentacam, he has a very thin cornea. Please, this child, as long as he's seeing, as anterior segment OCT show this opacity, as long as he's seeing, please give him a contact lens. And this is the last case. As we see here, we have a corneal opacity with semblefron, and this is always, can you imagine, can you see here that this is a corneal opacity? After I did surgery, when I removed the superficial, I found that the cornea is clear. So sometimes we got deceived that this patient has a corneal opacity. No, he has a semblefron with ocular cicatricial pemphigoid. For the sake of time, this is the last patient, that this patient has a PRK and he has a corneal infection and treated. I treated him, and after doing an anterior segment OCT, as we see here, he has a full thickness opacity. Can we put on the video, please? ممكن الفيديو؟ Yes. ممكن نسرعه سنة قدام بس سنة كمان. Always expect the unexpected in such patient, as we see here. Stop. Here I was planning that I'm going to remove the lens in such guy, and I will implant the intraocular pressure. As we see here, there is a plug obliterating this opening. So you have to remove this fibrous plug and reform the anterior chamber. In such case, you have to fill the anterior chamber with viscoelastic material in order to separate. You are not sure the cornea is adherent to the anterior capsule or not. My plan was to remove the cataract. Here, partial teraffination and peripheral separation is mandatory. And after you do this, as you see here, I succeeded that I peeled the cornea from the anterior capsule without opening the anterior capsule. As you see here, pull and relieve, gradually and steady force until you remove all this opacity. And then remove it, and as you see here, I didn't remove the cataract and I didn't do my surgery. I left the patient physic because he was young, he was 25 years. This is the post-operative of the patient. As we see here, the red reflex on the left, the 1 month after the red reflex, and as we see here, we save his lens. Conclusion. Proper approach to the corneal opacity should include history taking, examination, investigation. Anterior segment OCT is mandatory in all cases. Culture and sensitivity is a must in corneal infection. And follow-up is needed in corneal opacity that doesn't affect the vision. Although the lamellar keratoplasty is more difficult and time-consuming, it has many advantages over penetrating keratoplasty in certain cases. Thank you so much.
Thank you so much, Dr.
Thank you very much for this panorama of surgical technique in corneal opacities. It's my great pleasure to call on our dearest friend, Dr. Samir Rababia. He's one of the pioneer of cornea and refractive surgery in Miyako region. He will talk on new horizon in high myopia.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. أود أشكركم جميعا على حضوركم، وأنا سعيد بدعوتكم إياي للمشاركة إن شاء الله في بعض النقاط. وسعدت جدا بوجودي في ليبيا، وهذه أول مرة إن شاء الله لن تكون الأخيرة في ليبيا. حنتكلم اليوم عن نيو هورايزن، يعني وايدر هورايزن، حنوسع المجال. مين اللي يتحكم، أنا ولا أنت؟ اوكي، بسم الله الرحمن الرحيم. go on. فضلك. اوكي، wider horizon. لو جبنا normal patient، normal، خلي بالنا ان all these patients are normal patients and all the tests were normal: slit lamp, IOP, topography, tomography, refraction, pachymetry, etc. Everything is normal. And imagine this patient is minus 3.5، عليها astigmatism minus 1، axis 170. وبعدين شوف الايج، انا حاط لك ايج 29 مقبول، حاط لك cornea thickness 535 مقبوله، حاط لك central K value 42. يعني I have something in my mind when I selected this. الpupil 8.13. So all these data are excellent. So this patient will have an excellent result if you do his surgery. بالمقابل imagine ان الاستجماتيزم instead of minus 1 كانت minus 6. So with all the same data, he's not so good patient. حتفكر مرتين before you do it. لأنه very high astigmatism. وعلى العكس لو السفير برضو هاي، يعني سفير instead of -3 become -12, again he is not an excellent expected patient. في changes في الجيم ولو إن the same K reading, same corneal thickness, same age of the patient. خلينا نشوف ناخذ الاستجماتيزم الحالة وبعدين ناخذ السفير الحالة. الاستجماتيك سترومال ابليشن كل واحد فيكم طبعا عنده his own protocol. يعني when you have patient -3 عليها -2, you don't put this into your machine. You have your own protocol, you know that -2. In order to correct -2, how much you go? For my machine, I add 1.5%. يعني ال2 أسويها 3. إذن ممكن your machine is different according to your setting. Everybody his own. This is my own. This is Sami al-Rabi'a nomogram. So look at the astigmatism. It's 2.25. It became 3.375. هذا أول نقطة. النقطة الثانية, الاستجماتيزم has a coupling effect which is about 30%. ترجع تخصم 30% من 3.3 وتشيلهم من السفير, حتطلع النتيجة 2.4 عليها عليها 2.5. طيب هذا ندخل الحين فاكتور السن. لما نقول فاكتور السن يعني if the patient is 18 or less السفير حتصير 3.5 تقريبا, while if this patient is 49 or 50 السفير حتصير 1.5. so many factors, الage وبعدين حتشوف الاستجماتيزم is it with the rule or against the rule. If it is with the rule you go for this, if against the rule you add 0.1 extra. طبعا this is my own nomogram. Everybody of you has his own nomogram. Don't just put the data into the machine unless you are just starting. Anyway, فنتصور نشوف المريض هذا كان قلنا -3.5 عليها 6 degrees. ال6 if I multiply it 1.5 حتصير 9. إذن I have to correct 9 degrees or to put into the machine 9 degrees. And then if I take 30% of the 9 it will be 2.7. حرجع أشيل 2.7 من السفير حتطلع السفير 0.8. إذن what I give into this machine is -0.8 على -9 axis 30 which is originally 3.5 6 أصبحت 0.8 9. This is a normal femtosecond LASIK. إنما if you are going to do clicks, طبعا يمكن أحد يسألني what is clicks. Now we are not going to use smile برو, الأسماء هذه خلاص كلها يا إما clicks يعني شنو يعني كيراتو لنتيكولار اكستراكشن ريفراكتيف. كل العمليات هاي سواء سليكس سمايل سواء سمايل برو سواء كلير سواء اليت سواء سلك, they are different names انما تيجي تحت اسم واحد وهذا الاسم اللي حيعتمد عالميا. Anyway في الكليكس it is not 1.5 it is 1.1. اذا انا بديت اخفف صارت 6.6 اخذ الثلث تقريبا 2 اشيله من هناك. اذا النتيجه النهائيه اصبحت different. If I'm going to do clicks it's not the same if I'm going to do femtosecond. طيب شو الفرق بينهم؟ الفيمتوسكند 0.8 على 39, الكليكس 1.5 على 6.36. الفيرست one will take 144 micron, the second one will take 172 microns. إذا أنا I saved 17 micron only بالاستجماتيزم. إلى الآن ما اشتغلت سفير. 17 مايكرون. خليها في مخك الخطوة اللي وراها. الستروما الحين حنيجي على السفير لحالها. طيب ليش احنا ما نسوي مثلا هو لو -5 اوكي -8 اقول لا انا خايف. ليه انا خايف -8؟ لان انا خايف الريزيدوال ثيكنس عندي يكون اقل من اللازم وبالتالي البيشنت ممكن يدخل في اكتيزيا. حتقول لي شنو الاقل من اللازم؟ ما هو اللازم؟ اول كنا نقول 250 مايكرون, بعدين نقول لا 300 مايكرون, بعدين قلنا ال 40%. يمكن ما في بعضكم ما يعرف شنو ال 40%. ال 40% انك تاخذ الفلاب اللي هي 110 120 whatever your flap وتضيف عليها الستروما which is going to be ablated. المفروض مجموع الاثنين الفلاب والستروما ابليتد يمثل اقل من 40% من التوتال كورنيال ثيكنس. يعني انت تحتفظ ب 60% من التوتال كورنيال ثيكنس. لو كورنيا 500 مايكرون، 60% من 500 كم يطلع؟ 10 50 كم يطلع؟ يطلع تقريبا 400 أو يطلع 300 تقريبا. إذا أنت عندك 300 تشيل منها 110 فلاب يبقى عندك 190. إذا أنت تقدر تشتغل في 190 سرعة تحسبها بهالبساطة. نيجي هنا، إذا أنت خايف من السترومال ثيكنس فحتفكر في شيء آخر، تقول طيب أنا instead of إن أنا أgo so deep أنا أخلي smaller ablation، ولما أخلي السمولر ablation أنا عارف إن الدبث حيكون أقل، فأي want to save tissue إن أنا أصغر السترومال. في الواقع الخطأ هذا كونك تصغر دخلت في 3 مشاكل. الميكانيكال فاكتور اللي هو ريزيديال كورنيال ثيكنس، وهذا تكلمنا عليه، وقلنا ان لو انت عندك حتسوي له فول كوركشن لارج تريتيميزون حيكون على حساب الريزيديوال كورنيال ثيكنس، وهذا حيسوي لك اكتيزيا واضح. فانت حتفكر تقول طيب ما انا انا اسوي صغير. يعني شنو صغير؟ اصغر التريتمنت زون وبالتالي اكبر الريزيدوال اريا اللي عندي على حساب المسافه. واعتقد ان انا شاطر. انا مش شاطر لاني يلا اوكي وبعدين 1 2. طيب شوف الصورة بس، انسى لأنه هو المفروض في رسمة لنا. شوف الزاوية في الآخر اللي هي أطراف التريتمنت اريا، اللي هي احنا نسميها الركبة. في ركبة صغيرة هناك في الزوايا، هذه اللي حنتكلم عنها بعد شوية بسفيريكال ابريجن. كل ما صغرت كل ما الركبة عندك زادت، وبالتالي شيء اسمه سفيريكال ابريجن زاد. البيشنت يشوف 6 بالنهار، انما he will never be able to drive at night، وحنشرحها بعد شوي. المهم تشوف ان انت لما تصغر الجرح ترتب عليه شيئين. اول شيء الركبه زادت، ثاني شيء التريتمنت اريا صارت سمولر وصارت حفره. لما تصير حفره غير لما تصير مفتوحه، وحنتكلم عن هذا. ايوه، اذا انا صغرت عشان احافظ على التشو، ترتب عندي ان الجوينت او الركبه او السفيريكال ابريجن زادت، وسوى لنا عندنا سفيريكال ابريجن. وهذا الاوبتيكال فيجوال. اذا عندنا اناتوميكال اللي احنا قلنا الريزيدوال، والاوبتيكال الحين تكلمنا عليه. طيب نيجي نشوف هذه نورمال كيس. هذا انت سويت له تريتمنت كان 43 اصبح 39.9، يعني تقريبا انت صلحته 3 ديجريز. انما لوك ات ذا بريفري، البريفري كان يعني السفيريكال ابريجن كان 16 اصبح 15، حلو في السنتر. انما لما تطلع برا كان ماينس 14 اصبح السفيريكال ابريجن على 7 ملي 56. ستيل جود، 56 از نوت باد ات اول. بس يعني انا اوريكم انه كل ما انت تسوي انت قاعد تسوي شيء اسمه سفيريكال ابريجن. المهم ما تدخل في التوكسيك. طول ما انت في الجوانب سواء بوزيتيف او نيجاتيف، طول ما انت ما دخلت في التوكسيك سفيريكال ابريجن انت بنعمه. البيشنت كان سي جود ديبث اوف فيجن، بس اول ما تدخل في التوكسيك حيكرهك البيشنت. وطبعا حنشوف هنا نفس المريض هذا لو تسوينا نفس الحاله، لو انت صلحت ماينس 3 او ماينس 12، هل في فرق؟ خلينا نطالع نمره 12 اللي هي السفيريكال ابريجن كانت 0.5، لكن لما صلحت 3 صارت 0.134، ما زالت مش حلو مش بطاله. انما لو صلحت 12 صارت 0.4 very high degree. اذا السفيريكال ابريجن او الركبه او الزاويه بتزيد مع الهاير ريفراكتيف. وهذا شكلها لما نسوي لما نسوي المايوبيك كوركشن. وهذه الركبه واضحه الحين لما اعطينا تجسيد لها. وهذه حاله بعد ما سويت لها تصليح، يعني بعد ما المريض اشتكى ترجع تسوي له ابريمتري وبعدين ابريجن كوركشن. اونلي ابريجن حتلاحظ ان الكي ريدنجز 42.88 اصبح 42.8، يعني انت ما غيرت السفيريكال ابريجن ابد، ما غيرت الريفراكشن اوف ذا بيشنت، انما حتلاحظ ان الكيو فاليو اللي كانت 0.85 اصبحت 0.7. سو شارب فيجن، بس هذا لما تيجي تصلحه باي ابريجن. اذا انت دخلت روحك في مشكله وبديت تصلحها. حنيجي نتكلم هنا نحاول نفهم، لان في بعض الناس ما تفهم يعني شنو بوزيتيف ابريجن نيجاتيف سفيريكال ابريجن. لو قلنا لو اور اي ما يطلع. لو our eye is rounded، لو our cornea is circle which is not. لو our cornea is circle, the light from the center goes directly to the retina. بس once the light goes شوية away from the center, its surface if it is complete spherical حيكون الريفراكشن تبعه يختلف، وبالتالي at the periphery حيكون اللايت حيكون very close to the cornea, not down. بالمقابل لكن الله سبحانه ما أعطانا cornea spherical، احنا we have aspherical cornea. Once we go outside of the center الكورنيا يصير flatter, and then we can see that the light on the periphery it doesn't go so far, it goes down slightly. وهذا النورمال بروليت كورنيا، هذا بوزيتيف سفيريكال ابريجن. تسالني تقول لي طيب اذا هذا كويس، الصوره مش جايه على الشبكيه، اقول لك لانك انت نسيت اللينس. if you put the lens of the patient، اللينس مع ال periphery of the cornea both together they put the light on the zero plan and you have an excellent vision. لو سويت البيشنت هذا بوست مايوبيا، المايوبيا تسوي فلاتنينج في السنتر، وقلنا تسوي ستيبنينج في البريفري. فستيبنينج يعني ترجع الفلات، ترجع ستيب وترفع مره ثانيه، فبالتالي it increases البوزيتيف لفوق، it increases البوزيتيف لانه هو في الاصل بوزيتيف. بالمقابل لما تسوي هايبروبيك كوركشن فانت تسوي ستيبنينج في السنتر وتسوي فلاتنينج بالبريفري، وبالتالي هو less positive. بس they are all called positive لأنه ولا واحد منهم وصل للريتنا. unless you put the lens into consideration حندخل في النيجاتيف. اوكي زين، هذا للتسهيل. وهذا شكلها لما تكون بوزيتيف، الضوء بعيد، وقلنا ان احنا في عندنا توكسيك ليفل. لو ما عندنا التوكسيك ليفل هذا النعيم، وهذا اللي احنا قاعدين نستعمله عشان نخلي المريض يقرا اللي هم الاولد ايج تو ريد without جلاسز، ان احنا نلعب بالسفيريكال ابريجن بدون ما ندخله في التوكسيك، ونزيد الدبث اوف فوكس يبتدي يقرا بدون نظاره. اذا هذه الفكره، ولو صلحناه تماما صاروا all the lights look at the spherical aberration almost flat almost on the retina. طيب الحلو الوحيد، يعني احنا لو سوينا كل الريفراكتيف سيرجريز all of them they induce high order aberration بجميع انواعها. يعني صحيح احنا we are causing damage to the patient ولو انه so minimal، يعني شويه كوما على شويه تريفويل على شويه قاعدين نسوي definitely، وخصوصا السفيريكال ابريجن ما عدا الكليكس. يا سبحان الله، الكليكس الوحيد اللي ما يزود سفيريكال ابريجن، وبالتالي انا احس براحه اكثر ان انا ادخل اعمق. احنا قلنا كل ما دخلت اكثر كل ما سفيريكال ابريجن كان اسوء. فتصور لما اقول لك خذ راحتك انا مش حرفع لك السفيريكال ابريجن، اذا انت حتزيد، بدل ما كنت حتصلح 7 اصلح 8 واشوف السفيريكال ابريجن ما زالت نوت توكسيك ادخل ب9. اذا هذا وسع لي الهورايزن بتاعي، ان انا قلت لك سفيريكال ابريجن مش حزيدها لك، هي الوحيده الكليكس. الميزه الوحيده في الكليكس بحسب وجهه نظري السفيريكال ابريجن ما يرتفع. وهذه الحالات اللي احنا سويناها وشفنا طبعا ارتفع بس مش بالدرجه اللي تخوف. ونشوف هني مثلا مريض هذا نورمال بيشنت، الويف فرونت ايرور 0.2 محترم، سويت له ريفراكشن صار الويف فرونت ايرور 1.2. اذا he is much worse.
Time please.
I'm sorry I'll run. خلاص اسف. نفس الشيء 0.4 زاد 2 كل يصير أسوأ ما عدا كلير. أنا آسف المفروض ما استعمل كلير، كيلكس. ال 0.1 صارت 0.07. he is better even. طيب إذا خلصنا الميكانيكال والأوبتيكال. الاناتوميكال فاكتور اللي هو الكي ريدنجز. يعني شنو؟ we don't like dibs، ما نحب الحفر، يعني our tissue doesn't like dib. فإحنا لو سوينا سمول وعالجت كثير على أساس إنها سمول ما في خوف، الإبيثيليوم will immediately cover this area and حيحصل regression. وبالضبط هذا المثل لو أخذنا الجبال هنا، شوف من فوق الإبيثيليوم does covered a lot here. الإبيثيليوم here in this. إنما لما يكون واسع الإبيثيليوم does not really cover. فالإبيثيليوم عشان ما يخرب عليك لازم تسوي له علاج كبير، وهنا مش موجود. فهذا anatomical factor. وجدنا الآن إن في الكليكس والفيمتو سكند، الفيمتو سكند أنت لما تصلح -5، أنا I'm sorry بس it takes only 2 minutes. If you have -5 and then you look at your K readings كانت مثلا 45، ما تصير 40، تصير تقريبا 80% من ال5 شيلهم يصير 4. فال 45 يصير 41 الكي ريدنجز. يعني 80% تقريبا من الريفراكتيف ايرور حوله على كي ريدنج تعطيك القراءة السليمة. فأنت خايف تعدي كي ريدنجز معين عشان الابيثيليوم ما يغطيك. الكيلكس له ميزة إن it does not go so deep. الكيلكس 71% النورمال ليزك 82. ولو اعتقد this is the last slide. لو عندك patient -12 هذه مثلا يعني، وكان الكي ريدنجز 43، لو حتسوي له فيمتو سكند حيصبح 32، انما لو حتسوي له كليكس حيصبح 34. 2 دايبترز، وانا في عرض ال 2 دايبترز. اذا انا وفرت 2 دايبترز، وفرت لك سفيريكال ابريجن اقل، وفرت لك في الاستجماتيزم 17 مايكرونز. all this will give you higher chance انك تروح فور. ومش هنضيع وقت كثير هنا. هذا الفرق يعني ال 43 صارت 37 في نورمال، ال 42 صارت 36 6 ديجريز. انما الفرق هناك من 9 صارت نص، يعني 8 درجات ونص صلحت، بمقابل ان انا غيرت 6 مايكرون وليس 7 مايكرون. وانا اسف على التعطيل وشكرا جزيلا.
So our next speaker is Dr. Muftah Al-Jabri. He will speak about amniotic membrane.
السلام عليكم، مساء الخير. اليوم بنتكلم عن الامنيوتيك ممبرين. الامنيوتيك ممبرين to energy and regeneration corneal tissue هي case report. تمام. بوينتر ولا عندكم انتم تحكم بس؟ طبعا الكونيستروما is critical for corneal transparency and refractive function necessary for vision when corneal stroma is altered by disease as injury or scarring. However, is referred to loss of transparency can occur طبعا. Corneal pathology corneal stroma pathology is cause of millions of cases of blind globally, and also corneal transplantation is the standard therapy as several global deficit of donor corneal tissue طبعا and eye banking infrastructure exists. هذه طبعا ال 100 year challenge. طبعا هذا الامينو membrane الامينو membrane a fiber application from fresh amino membrane from placenta طبعا used for reconstruction of skin والcornea والvagina and urine matter. والامينو بروسيس طبعا a fiber application forms من stem cells fresh frozen plasma fresh frozen amino membrane dried amino membrane ولا حتى وصلوا لي يديروا توبيكال امينو membrane. طبعا سترايزل نتاع الامينو ممبرين من الانترافويلت سترايزيشن دراي امينو ممبرين فريش اند درايد امينو ممبرين من 1900 ل 1981 وبعدين تطور لحد 2018 و2021 للسولبلايزد امينو ممبرين ومينلايزد امينو ممبرين والامينو سيتوكين اكسترا والامينو ممبرين بويدر. اي تمام. Stromal injury are most commonly caused by trauma such as chemical, thermal and mechanical abrasion or by inflammation and infectious disease. هذا طبعا الاسباب اللي هو في الغالب اللي موجود في stromal injury. Corneal epithelial and endothelial have been subjects of interest in ophthalmological research for quite some time. Still stromal ما اشتغلوش على هلبة. Next. It is only recently that stromal replacement have become equally studied subject. أنا الكلام هذا باش نحكي على الكيس اللي حصلت معنا. Currently clinical option for stromal replacement كيف ما نعرفوا. Next. Next. طبعا ممكن human donor corneal او artificial corneal Boston and osteon odontokeratoprosthesis والtissue engineering طبعا تو تايبس ممكن منها سيل ديبندنت في الابيثيليوم اندوثيليال لايرز او سكند تايب اللي هو ابروش هو التيشو انجينيرنج از ذا سكافويد بيزد ابروش فور ستروما وهذا اللي ممكن حصلت يعني تو. نكست نكست. طبعا الامينيتيك ممبرين ترانسبلانتيشن كورنيا also preserve and support stem cell whilst inhibiting neoplastic inflammatory angiogenic and fibroblastic cells. Next. When applied in combination this biological property support and facility want healing. حنتكلموا تو شويه على الكيس اللي حصل معنا. الامينو has been shown improved pain management طبعا حتى في conjunction مع delivery anti microbial benefit يعني الامينو ممكن يحسن البين مانجمنت ايضا حتى انتي ميكروبيال. نكست. طبعا هو اصل امينيتيك ممبرين كومبايزد من 5 لايرز شكل الكورنيا وهذا التيشو بتاعه من 20 ل 500 مايكرون. طبعا هو يحتوي على ابيثيليال سيلز عندها بيزمنت ممبرين الكومباكت لاير وفيها فايبروبلاست از يعني شكل الكورنيال وفي سبونجي لاير والكورينيل الكورنيال. الامينيتيك ممبرين كونتين فايبروبلاستيك وبرونتيز انهبيتور وانتي انفلاماتوري وانتي سكارنج وانتي انجينيك ثيرابيوتيك اكشن. الكيس اللي احنا بنتكلم عليها Next it. طبعا كانت كلينيكال اوبشن فور ستروما ريبليسمنت هي كما حكينا عليها هيومن دونال كورنيا والارتفيشال كورنيا والتيشو انجينيرنج. تقريبا كان يرجع بينا السلايد بتاعنا احنا زي سرعه شوي. ثاني بقى التركيب الامينوتيك ممبرين هو يشبه كثيرا الكورنيال تيشو غير الطبقه الاخيره. طبعا هذه يعني احنا يا اما الجرافت بتاعنا الامينو ترانسبلانتيشن يا اما ابيثيليال سايد اب واللي هذا اسمها انلي جرافت الامينو بريبليس لوس سترومال تيشو اب تو بيزمنت ممبرين او باتش ترانسبلانتيشن وهو بليسد على الابيثيليال سايد داون اوفر الوند بريفري از تمبرال بيولوجيكال بليسنج او كومباينيشن اللي هو نقول عليه ساندويتش امينيتيك ممبرين. Next it. Case report هي female 28-year-old woman present at our clinic with history of chemical injury of left eye since 16 years back. At presentation her visual acuity was hand movement with no any chronic illness. Next it. Slit lamp examination was done. Showed corneal opacity, symblepharon at upper and lower eyelid, superficial and deep corneal neovascularization. طبعا احنا الفكره بتاع الامينيوتيك ممبرين فور السمبليفرال ريليز. هذه احنا طبعا درنا السمبليفرال ريليز ودبرايتمنت واعطينا انتي افاستن فتره وبعدين نبغى ريليز السامبليفرون ريكارنت سامبليفرون فدرنا الامينيوتيك ممبرين واحنا نديروا في دبرايتمنتس. حصل ان طبعا هي لان هي اصلا اوريدي كيميكال بيرم فالكونيال سترومال كان ضعيف او تن كونيال سترومال فاحنا ندير في الدبرايتمنت وصلنا ل نيرلي الديسمنت ممبرين فهنا ستوبت وعملنا الامينيوتيك ممبرين وكلوز يعني ستيتش الامينيوتيك ممبرين افتر 1 ويكس. طبعا هذه الصوره بتاعت بعدها باسبوع كانت الكونيال 151 مايكرون وتشوفوا في الاريجولاريتي بتاع الكورنيا. نكست. After 20 days not regeneration of corneal stroma وبدأ في re-engineering في التيشو وحتى التكنس بتاعنا بدأ يزيد 221 والترانسبرنسي بدأ يظهر أكثر. يعني الفيجن ما تحسنش هلبة بس يعني بعد 8 شهور كانت الكورنيا بالشكل هذا يعني وصلنا حتى يعني الريجنريشن كانت اكثر والثيكنس زاد والكليرتي وبدت اوضح وحتى الشكل بتاع الكورنيا بدت افضل والفيجن بتاعنا تحسن الى كاونت فينجر 4 متر. طبعا الكونكلوجن الامينيوتيك ممبرين cover most of tissue enaging pyramid compound provide appropriate extra corneal membrane cells and different kind of growth factors. still طبعا هذا قاعد تحت البحث وتحت الإجراءات ما فيش هلبة عليهم. نتمنى من الناس اللي هم عندهم خبرة أكثر يفيدونا في المجال هذا اللي ممكن يفتح لنا باب ثاني. وبارك الله فيكم.
شكرا دكتور مفتاح. Next speaker دكتور خليل الرايس dissect and make comparison.
السلام عليكم. أنا دكتور خليل الرايس من تونس. أشكر الهيئة المنظمة على الدعوة. We're going to speak about endothelial keratoplasty, which is a revolution nowadays in corneal graft. And the main pathology are Fuchs, endothelial corneal dystrophy, and pseudophakic bullous keratopathy. And it consists in a selective displacement of the malfunctioning layer. And the major technique are DZEC, ultra-thin DZEC, and DMEC. And these techniques emerged in the early 2000s. So the advantages of endothelial keratoplasty on PKP are obvious, with less induced astigmatism, lower risk graft rejection. So the DZEC graft consists on descemet membrane with a thin layer of stroma, and the thickness is between 100 and 200 microns. The ultra-thin DZEC, the thickness is less than 100 micron, and in DMEC, the graft is done with descemet and endothelium with a thickness between 15 and 20 microns. So the trends nowadays are for endothelial keratoplasty, which is used more than PKP in the United States, and DMEC is now joining DZEC in the trend of the keratoplasties. So surgical steps for all techniques of endothelial keratoplasty are first graft preparation, after that host descemet membrane stripping, and graft insertion, enfolding, and centration. But first and foremost, patient selection is fundamental. So both DZEC and DMEC can be performed when endothelial keratoplasty is indicated, but we will prefer DMEC in Fuchs dystrophy, in younger age, if you have good preoperative visual acuity with no other ocular comorbidities in routine cases. And DZEC will be preferred. Sorry. Sorry. And DZEC will be preferred in technically challenging surgeries, in eyes with low visibility, in eyes with tubes, with glaucoma surgery, with large iris defects, with abnormalities, with aniridia, eyes with aphakia, vitrectomized eyes, and pediatric patients. So whenever there is a high risk of DMEC failure, it's better to use DZEC. So graft preparation, in DMEC the graft is thin. It can be prepared in the OR manually or prepared in the eye bank. In DZEC, the graft is thicker, so easier to handle and to manipulate. And for preparation, we require an artificial chamber. It can be manual or automated, which is most costly technique. And the use of microkeratom make the graft more predictable, more predictable with a larger diameter and with the control of the thickness. Second step is the descemet membrane stripping. It can be under air or under viscoelastic. Under air is simpler and less time consuming. And under viscoelastic, we have a better space maintenance and is more useful when we plan to do a combined surgery. Sorry. So descemet membrane stripping is almost the same between the two techniques, but the stripped zone must be larger than the graft in DMEC, and in DZEC we can have the same size and overlap is tolerated. We will see that in videos. So in DMEC, the incision is small, the graft is folded, we will use tubes under center. The enfolding is delicate and there is a high risk of inversion. On the other hand, in DZEC, the incision is large, the graft can be folded or not folded, we will use forceps and glide, and the enfolding is very easy with less risk of inversion. So let's see the technique. So the desmethodorexis, the technique is the same between DZEC and DMAC. We can do it, as I said, under air. So under air, the visualization is better, but we can do it under viscoelastic. And under viscoelastic, the maintenance of the space is better. We will use viscoelastic if we plan to do a combined surgery with a phaco. And if you use viscoelastic, we have to clean very thoroughly the viscoelastic after the desmethodorexis. So we start by scoring in the desired size. In DMAC, we score at, let's say, 9 millimeter if you will use 8 millimeter graft. So the overlapping between the host desmet and the graft is not tolerated in the DMAC, but it can be tolerated in DZEC. So after scoring, we start by stripping with the inverted Sinski, and we have to take care not to harm the stroma, because if you harm the stroma, we can induce fibrosis in the interface, and we have to take care not to let any remnant of the desmet, because it will cause a detachment in the postoperative period. After preparation of the DMAC graft, we will load the graft in the tube. There are many kinds of tubes and inserter made in glass. We can use cartridge. Here we have loaded the graft. The graft has been stamped with an S, which make easier after that to have the good position of the graft. So we inject the graft. We see the graft here is stamped with an S. Here is the S. So we inject very smoothly, and after that we will lower the pressure in the anterior chamber, because there is a risk of extrusion of the graft when we take out the injector. I put a suture so to secure the main incision. After that, we have to center the graft, and after centering the graft, we will try to open it. So we open the graft by a no-touch technique. We preferably don't use the technique and maneuver inside the anterior chamber, so they are indirect maneuver to open the graft. So we center first, and after that, we open the graft. The main challenge is to get the good position, the good orientation of the graft. Here's the case where the graft is inverted. So we have maneuver, like Manson maneuver. You introduce the cannula. If the cannula is stained, so the graft is in the good position. It's not stained, so the roll is the upside down. And we try to check the S mark. Here, the S mark, we can't see it very clearly, but it's not an S mark, it's a 2 mark. So the graft is inverted. So we have to rotate the graft by flashing the graft to rotate it. So here is the maneuver. We flash the graft, we rotate the graft, and we start from the beginning. We center the graft first. So you see, sometimes the opening and folding takes time and a little bit tricky. So we center. We have to be very patient with indirect maneuver. Here the graft is centered. We start by sweeping the cornea, creating waves in the anterior chamber, and these waves will open the graft. Here the graft is centered. It starts to open. We try to open the border of the graft with this indirect maneuver. It opens progressively. We decompress a little bit the anterior chamber. So when we decompress, we lower the pressure in this side, and spontaneously the graft open in that side. When we finish, we put air. You see the S mark. we are in the good position, so the surgery is over. So on the other side, we have the DZEC. Here is the DZEC. Can you start the video, please? Okay. Here's the DZEC. We have an ultra-thin DZEC, so the thickness is about 100. So we use the Buzine glide with the forceps, and the graft is thicker, so the unfolding is very easy. So this is the case in the opposite. The first case was Gutata with good visibility. This is an advanced post-phacokeratopathy, so with the advanced cloudy cornea with neovascularization. And you see the unfolding is very easy since we have the graft handled by the forceps. So it takes a few seconds to unfold, and we finish the surgery by injecting air. So if you compare the two techniques on surgical outcome, we will compare the three techniques, DMAC versus DZEC. So in terms of visual function, it's better with DMAC, with less hyperopic shift, and corneal thickness is lower with DMAC, less cell density loss with DZEC, because with DMAC we have a higher need for rebubbling, and this will lower the endothelial cell count. So here, between DMAC and DZEC, DMAC is better. So if you have to compare ultra-thin DZEC with DZEC, visual function is better with ultra-thin DZEC, but we have the same density loss rate with the two techniques, and the ultra-thin DZEC is better. Finally, we compare GMAC with ultra-thin DZEC. We have a faster visual recovery for GMAC, but in the long term, after 6 months or 12 months, there is no difference between the two techniques. We can say that the two techniques are more or less equivalent, but don't forget that with ultra-thin DZEC, the technique is simpler, more forgiving technique that can be performed in deemed challenging cases. So in terms of visual acuity, as I said, in the first follow-up period, the visual acuity is better with DMAC, but after 6 or 12 months, ultra-thin DZEC and DMAC are equivalent, and both techniques are better than DZEC. So in conclusion, DMAC offers the best visual acuity and is dedicated for eyes with clean anterior segment and no significant anatomical complication, is preferred by highly experienced surgeon and with comfortable with delicate rolled graft. DZEC is easier to perform with lower immediate complication rate, with higher endothelial cell counts, is dedicated for eyes with complex anterior segment pathologies. And ultra-thin DZEC is the middle ground between the two techniques, offer best corrected visual acuity, and maintains the surgical ease and security of thicker grafts. So each technique has its advantages and inconvenience, and every corneal surgeon must master all techniques and choose the appropriate one for each clinical context. Thank you for your attention.
Thank you very much, Dr. Rice, for this nice comparison of these two techniques. The organizer allowed us a few minutes for discussion. We have 2 microphones in the audience. We'll have a group discussion, so any question is welcome. So if you want to ask a question, just ask for the microphone. Meanwhile, I will ask my co-moderators if they have any question or comments about the presentation of this first session.
No comments. Everything is okay, I think. But if anybody wants to ask a question, yeah, this is very interesting. I forgot. Yeah, I'm strange that the tissue has been repelled again. And I asked him, did he do confocal microscopy to study the new tissue? Is it the same? He said it's the same. I think it is very promising, and we have to look for it. How to generate a new tissue out of amniotic membrane. This is beautiful.
Okay, we have one question there.
Thanks, Dr. Rania, for your nice presentation. It's not a question or just discussion for the case of corneal infection you did for hair bulk, the second eye for the woman. I will add very small tricks. At the end, after I finish the case and I go for the desmet membrane, I put betadine eye drops by concentration of 0.05 for 2 to 3 minutes, because there is if there is any residual infection في البeds, I noticed that the results is more better and no recurrence of infection. What do you think?
Of course, before starting the dissection, I already put the betadine eye drops. I agree with Dr. Amir. This is very important that you keep giving all the weapon that you have in order to prevent the recurrence of the infection. But by all means, there is no 100% a method we are guaranteed that it won't recur. But which I put the betadine before putting the graft, and I follow up the patient I kept her in the hospital to see her almost every hour for the first week. But for me, I put the betadine before removing the corneal infection.
Any other question from the audience?
Dr. Hamdi Abdel, about the ultra thin or the thin cornea and the CXL. You give us the Hafizi protocol and results. The Hafizi protocol and results, all the time I found it is very difficult to compare this with the other population. Maybe it is done for only the Swiss people, because even the back CXL, he gave the result about more than 90% success rate. Even this percentage, it is very high. The literature reviews in the WOC conference 2025 and in the ISCRS 2025, there is a high risk when you are doing CXL in less than 300. You are saying I'm doing this above 300, but the results which you show it with the percentage, it is less 300. But there is the new protocol. This one, I think it is more logic with advanced technique like Smile Pro. We are taking the smile and we are inserting this with even a smile in the very thin cornea, and then we will do BRK turbo guided with CXL. This is making the cornea reaches to up 400 or 400 something. Even the second point, he's using the accelerated CXL. He's using the 25 minute, 20 milliwatts for 5 minutes, and he's using the 30 milliwatt 3 minutes, which is up till now, it is not FDA approval. What's your opinion about these protocols? I think this given by Professor Hafizi.
Yes, all the trials that Hafizi have tried is regarding the original Dresden protocol, which is well authenticated and every result in it is accurate. So I don't use an accelerated protocol in my patients. I don't treat less than 300. So maybe first few cases I treated 290, but later on I started not to treat these patients. I see how much is the corneal endothelium, and I plan from the corneal thickness, sorry, the pachymetry, I plan the surgery before. For example, if I find the corneal thickness 330, I wouldn't go even for cross-linking in this eye. But the idea that you are saying about implanting, there is a lot of trials Even I have seen somebody who's using porcine tissue, and they are putting it inside the cornea in order to make more thickness in the cornea. This is something that's still going to come, because I think there will be facing a problem in the future of interface opacity. I don't think, I don't have any experience with that, so I cannot answer about that.
Have minutes? Yes, this is only 30 seconds. I want we don't like to send message for the audience if the corneal thickness is less than 300, we're not able to do anything for it. Even about the Hafizi protocol with accelerated CXL. This is the message.
Yes, yes. I agree totally. What I'm doing is I'm using a Dresden protocol, and I'm using it just for 300, and you have to be very careful about that, because you shouldn't sterilize the endothelium, because if you sterilize the endothelium, you will end up with perforated corneal trauma. Thank you.
Thank you very much. We have to move on. Thank all the speakers for this first session, and I should call the moderator of the second session.
الباناليست اللي ان شاء الله المودريتور دكتوره رانيا الخوجه، دكتور خليل رايس، دكتور اسامه جليدي، دكتور امير مصطفى.
First presentation, Dr. Salah Mahjoub, and current trends in keratoplasty.
Thank you very much. First of all, congratulations to the organizing committee for putting together such a wonderful meeting. It's really an honor and a pleasure for me to be here for this second edition. So I would like to share with you the evolution of keratoplasty, indication and surgical technique in the past 8 years at our eye center. So 8 years ago, the first indication for corneal graft was keratoconus, about 44% of cases, and the second indication is bullous keratopathy, 18%. And last year, there is a switch. Keratoconus is only 25%, second place, and first indication bullous keratopathy. And this is due to the widespread of cross-linking, preventing the progression of keratoconus to advanced stages. So in keratoconus, the preferred technique is the DALC, because we want to preserve the endothelium, and we are able to achieve it in about 3/4 of the patient, and it's about the same last year. OCT will help you for the indications. You see the right eye has a deep scarring to the endothelium. This is indication for penetrating, and the left eye, it's only scarring in the stromas or indication for deep lamellar keratoplasty. Can you start the video, please? So we use femto-assisted technique. Can we have the video? It was working. Okay, so we do lamellar cut using the femtosecond laser and leaving only 120 micron at the thinnest point. Next, please. And by injecting in the deep part of the stroma, the rate of achievement in the big buccal is very high, about 85%. And we can achieve Desmet bearing in about 95% of cases. And you see here at the end of the surgery. In case where the cornea is not very transparent, like this case of macular corneal dystrophy, can you start the video? We do also a technique using femtosecond laser. But here we'll use intraoperative OCT to guide the needle injection of air in the stroma. And it's very successful even in this opaque cornea you see here. Post of the cornea is very clear, and the OCT looks like a penetrating keratoplasty. Regarding bullous keratopathy, 8 years ago, only about 60% of cases was done using DMEC surgery, but nowadays 80% of bullous keratopathy are operating using the DMEC technique. And the reason for that, because there is so many technical advancement, and the surgery protocol is much improved. Even advanced cases like this one, just by removing the hyperpresic epithelium, they see the cornea much more clearer, and this is allow us to do DMEG. Even in this case where visibility is not excellent, also using intraoperative OCT, you can orient the graft here. You see the roll is inside and the endothelium is outside. The reason bullous keratopathy is the first indication because there is a widespread usage of specular microscopy before cataract surgery. And about 40% of the cases are combined phaco and DMEC. And just will show you a video. Okay. So you do your phaco a normal way, and here just the rhexis of the endothelium under air because you have better visibility. And this is the injection in the anterior chamber through the 2.2 millimeter incision. This is using cannula to check the orientation of the graft and just putting an air bubble to secure the graft inside the eye, and you just center it. Also a good indication for DMEC is rejection, but no, too bad we see the patient very advanced stage. So only 21% of cases in 2016, and now better percentage, 4%. Just illustration, this is a failed DZEG. So here we just used forceps to remove the DZEG, which is scarred and thickened, as you see here, under air for better visibility. And this is injection of the DMEC roll. So here we check the orientation, and then just using a sweeping maneuver, we can open the graft. Okay. And last thing, it's we try to use as much as we can split cornea. So 8 years ago, only 12%, but now recently it's up to 20% to use a split cornea. What we mean by split cornea is that the same cornea is used for DMEC and for DALC surgery. So in conclusion, bullous keratopathy is now the first indication for corneal transplant and keratoconus in second position. DMEC is the preferred method, and it's possible in about 80% of cases, and it's combined with phacosurgery in about 40% of cases. Could you advance, please? Next. Femtodalk is our preferred technique. It is possible in about 63% of patients. And finally, unfortunately, indication for PKP, which has much more higher complication, still indicated in about 44% of cases. And thank you very much.
Next speaker, Dr. انشراح.
السلام عليكم. I want to talk about the role of anti-VEGF in keratoplasty.
الصوت دكتورة انشراح لو سمحتي قربي من المايك شوية.
تمام. My patient 70 years old presented to coronary OBD, complained of poor vision, right eye after cataract surgery since 20 years back. On examination, visual acuity right eye PL, left eye 636. هذا On examination, right eye PL, left eye 636, right eye conjunctival congestion, corneal opacity with deep vascularization, and no anatomical corneal nimbus is visible. Anterior chamber, no more details. Left eye pseudophakia, fundus, chorioretinal degeneration, pale optic disc. Investigation, ultrasound done, retina looks flat. The patient considered high risk for rejection due to vascularization and decreased stem cells. We explained the poor prognosis for the patient, and we decided to do BKB for him with guarded prognosis. BKB done in 26/5/2023, BKB done with unfortunate event with Trifan 7.5 and Bunch 7.75. Post-op management, ciprofloxacin tablet 500, 1/2, 5 days. Bradford eye drop 1/6, Vigamox antibiotic eye drop 1/6, Hyalocomode 1/6. Post-op examination, visual acuity counting finger close to face, a graft clear, suture, okay. This is picture post-surgery. Follow-up, after 1 week, graft clear, visual acuity 0.5 meter. After 2 weeks, patient had epithelial defect and treated with bandage contact lens, alternate with the plasmapheresis. After 1 month, new vascularization become near to the graft. We started treatment with subconjunctival with anti-VEGF. Continue with this regime every 3 weeks for consequence 3 times, then monthly for 10 months. Last anti-VEGF given at 22/5/2024, last visit visual acuity 5 meter, graft clear, my patient satisfied by his vision. No more epithelial defect and vascularization. Take home message, anti-VEGF has a major role to decrease rejection in high risk patient for keratoplasty. This is my patient and my Prof. Dr. Samia. Thank you.
شكرا دكتور انشراح. خصوصا التايم, that's the best timing على فكرة. It's a pleasure to have next speaker, Dr. Hussam Ziad, when ectasia is not ectasia, and looking forward for this talk.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله صلى الله عليه وسلم. First of all, I want to thank gratefully Dr. Rani Al-Khoga for the kind invitation, and Dr. Sarah and the all scientific committee, Dr. Sami, and all of the great team. And my talk today about when ectasia is not ectasia. I will tell you some of my cases which actually was mimicking the ectasia presentation, but they are not, or they were not at the end. Let's start. Starting with the first case, 38 years old female with a past history of LASIK. 2 years ago, I was a surgeon. On last visit, which was 1 year after the surgery, the unaided was 6.6. And we were smiling. On this time, in the July 2019, she came again to a clinic with the panic and depression with rapid drop of vision. And astonishingly, the visual acuity was 160 in the right eye and 360 in the second eye. The best corrected hardly was 260 and 660 with this refraction, which is very strange refraction, not matching with anything. With normal intraocular pressure in the fondi, very minimal KPs on the back of cornea, which was negligible at that time, almost clear corneas. And we were so sad, and I was asking who switched off the room's light. This is the slit lamp photo for both eyes on the first visit. And I couldn't explain what was happening with this patient. So I started an empirical treatment like of the lubricant, like of steroid, to see the patient again and think again after. And sent her for pentacam. And look here at this pentacam photo. You will find the first striking map is the topography map with this inferior, central, and inferior steepening. In patient with past history of LASIK, the first thing to think for is the ectasia. And the operator told me, sorry, doctor, I think it's ectatic case. And more and more with my professors in the same center, they told me it's an ectasia, post-LASIK ectasia. Yeah. I was shocked on that time, but when I collected my mind and thought again with closed eye first, I found that the thinnest location in this eye with this thickness 539 micrometer is totally up, which is plus 1.8. It's not matching with the steep part of the cornea, the first sign which excluded the ectasia. And when I continue the thorough examination for this patient, I found that the posterior elevation map was completely normal. No ectasia without back elevation, as we know. And this is for the left eye, the same pattern. And then I realized that this patient, which was expressed firstly by the all ophthalmologist, saw this picture that it's an ectasia. It's not totally ectatic case. And I sent for the anterior segment OCT, where I found that there is a high pachymetry with a thick cornea, but the line of the posterior part of the cornea, including the endothelium, looks within normal. And look here at the specular microscopy should a little bit or normal, completely normal pattern. And look down here, the refraction, it's not matching with the manifest refraction for this patient as well. And started to, with the minimal treatment I told you about, started to improve to 560 and 36 in the left eye, which was better. And this was the first treatment I started with, the normal saline, 5%, prednisolone, and lubricant. But 2 weeks after, she came again to the clinic with this picture, where I have realized this patient is a case of lisiform keratitis, or disciform corneal or stromal edema. So I changed the mind about this case and started to rethink about the pathology, which could be the cause for this strange and unusual presentation. Look here, this is the photos. The next slide. So, when you think in such stromal edema or stromal keratitis, it could be viral or autoimmune. And to be safe, we have to put the first priority for the infection to avoid the aggravation and flaring up of the infection if I started with the steroid. So I start with the oral acyclovir, the complete dose, the topical ganciclovir as well, fluoromethylone, a very low dose of fluoromethylone, guarded dose, and immunomodulator. After 10 days with no response, so I shifted aggressively to the autoimmune therapy together with a consultant of autoimmune diseases. We started with the systemic methotrexate, oral prednisone, high dose, together with the topical hydrocortisone and pyonidine. After 2 weeks, really she showed a marvelous improvement. And her pentacam started to be much better regarding the thickness and regarding the steepening and the pachymetry map. You can see here, this is for the right and this is for the left. And you can compare between the first presentation and the second presentation of this patient. Look here, the difference. The key max was 45, sorry. There is some delay in the movement. So the old patterns in this pentacam, it showed some a very good improvement. Regarding the Kmax in the front was 54.4 diopter, and it was 56.9, almost 57, and it became after that 54 in the right eye, and the thickness changed a lot. The same for the left eye. Here, the Kmax in the left eye was 51.3, and it became 45.8 with very good step. 3 weeks more, much better, more improvement, and it regained, she regained the clarity of the cornea again. This is the photo slit lamp for the last visit with unaided 612 and 609 almost cornea, clear on that time, restored hair vision and mood wellness, and me as well. The second case, if I take few minutes, and this, please remember this photo, you will find it in my case. Clinical data for this case. 26 years old female touring for refractive surgery. Refraction, right, -1 sphere and -8 cylinder, and left -1 with -6 cylinder as well. The unaided visual acuity was 360, just in both eyes. The best corrected with that refraction was 624 and 618. Normal IOP, the cornea, I will show in the coming photo, the clear lenses and normal fundi. Look here, the slate lamp photo for this patient. You will find the center part of the cornea is completely clear, but look at the mid-peripheral and the peripheral part of the cornea, like that of the arcus senilis. But actually, this patient is still very young regarding the senile changes. But it's unusual form of extensive peripheral degeneration, which is not lipoid degeneration or other parts of the stromal dystrophy, but showing this image as you see in the left and right eyes. And remember, this is the pentacam for her. You will find these abnormal patterns, but they are not matching with any pathology. You cannot decide if this patient is keratoconus or there is any ectatic changes like the pellucid marginal degeneration or other forms. But look here, you will find the back elevation is irregular, but still within normal regarding the center part. There is steepening in the superior and the inferior parts of the corneal topography. But as we know, this is not the classic pattern of the keratoconus or ectatic situations. And you will find that this is a normal or unusual steep cornea, which is not abnormal. And look here in the other part, you will find that the thinnest part is completely out of the center, is plus 1.4. It's just 466, which is thin, but it's out in the superior part of the cornea. So what do you think about this case? It's ectasia. Look here at this drawing, you will find that the cornea is divided into two circles. A smaller one with a clear and larger one, including the degenerated part of the cornea, giving the T-letter shape. So, what's the diagnosis? Is it keratoconus? According to my experience, not. Then what to do in such case? In my opinion, I found that the case is matching with the steepening of the center part, the thinning of the peripheral part. Like that happening when you go for hyperopic correction, you are ablating in the mid peripheral part of the cornea, which makes the center part of the cornea steeper. So it is a normal process happening to the center of the cornea, going to be steeper because of thinning in the peripheral part of the cornea. So it is not ectasia, but could you do? It's not tertiary marginal degeneration or any advancing disease, but peripheral corneal degeneration and no more. So the management thoughts could be customized ablation procedures, topo-guided or wavefront guided or others. If you look here at these parameters, it's still matching. It's abnormal, but it's still not ectatic case. And I did for her a topo-guided topo-guided customized ablation using the wave-light device. With flip in both eyes, it was successful surgery with very good outcome. The unaided came to be with 2 lines more than pre-op. After 3 years of follow-up, she is still stable and happy and praying for me. And I will finish with this third case, the Turkish Sufi dancer sign to announce about my sign, Ziyada Orma sign. Look this flying skirt. When you find this pattern in the corneal topography, what do you think about? 37 years old female patient was sent for me for keratoconus management. And the surgeon who sent her said it's a keratoconus for intercorneal ring segment. The manifest refraction was -6, -2, -7, -3, as you see. The best corrected just 0.2 and 0.4. 3 months before, the best corrected visual acuity for this patient was just 0.9. Look at her pentacam. You'll find this picture. Look here, it's obviously in the topography there is steepening, so the first look you will decide that this patient is keratoconus. But give yourself a time, please. Think again and again in the refractive surgery before deciding the diagnosis. I know that the pattern is striking and deceiving at the same time to say that the patient is ectasia, but actually not. Look here. And compare between the flying skirt of the disc dancer and the flying bridge shape changes in the corneal topography map. You will find they are almost the same. This is the Pillin Ambrosio, just in the yellow region, or the yellow zone, and this is the comparison between both to realize how to bought the Orma Zeta sign, as we said. It's just inferior steepening with double wavy contour without superior limb. Should be come with mild, moderate, and severe changes. The differential diagnosis in such cases could be contact lens wearer, no autoimmune disease, no corneal degeneration or opacities. Please do epithelial mapping in such cases. Discontinue the contact lens and do new corneal imaging. Regarding this case, look here. After just 10 days of discontinuation of the contact lens, she came with this completely different, okay? Look here on the left side and the right side, the same map. You will find a complete change from the steep part to the normal cornea. So don't be hurried to diagnose. Yes, okay. And finally, I have to finish my presentation because of the time, but I think the message was clear.
Dr. Hussam,
Thank you so much.
Time over, Doctor.
Thank you so much. I finished.
Next speaker, Dr. Ala Diab, chloroquine-induced corneal session deposits. Ala, female, okay.
Assalamu alaikum. I would like to welcome our doctor and professor and our dear visitor. And I would like to thank Dr. Arania for this organization. Today we'll talk about chloroquine-induced corneal deposit in case of 33 years old women with systemic lupus. Understanding the ocular side effect of chloroquine is vital for optimizing patient care in lupus management. Chloroquine is an antimalarial drug with immunomodulatory property. It has been widely used to treat autoimmune disease such as rheumatoid arthritis and lupus. A mechanism of action of chloroquine interfere with metabolism of parasite, modulate immune response by inhibiting antigen presentation, and corneal interaction accumulate in corneal epithelial. Influence early corneal endothelial cell function and corneal transparency. Potential ocular side effect. Accumulation of chloroquine within corneal endothelial and epithelial may affect the corneal clarity, change in endothelial morphology and density, impact corneal swelling and visual acuity. Cumulative dose. The cumulative dose over 1,000 grams of chloroquine is associated with higher risk in corneal deposit. Duration of use more than 5 years may increase the risk of cumulative dose exceeds the recommended limit exceed. Our recommended dosage is 250 milligram daily, which go to 91 gram annually. Our case was 33 years old woman, case of SLE, presenting complaining of blurred vision and since 2 years, and with ocular discomfort and foreign body sensation. Her visual acuity was 636. Her ocular examination found there's bislet lamp vortex keratopathy observed bilaterally. No retinal pathology was detected on examination. In 5 years of using chloroquine, there was corneal deposition and foreign fluorescent stain show severe dryness. The patient was found to have a significant keratopathy without retinal pathology, which is unusually for chloroquine. Vortex keratopathy is known as corneal varicella, characterized by diffuse gray-white word opacity on the cornea, accumulation of chloroquine in corneal endothelium, leading to alternated lipid metabolism. Differential diagnosis is we found vortex keratopathy in Fabry disease, tamoxifen use in breast cancer, amiodarone in cardiac disease, diclofenac in arthritis, cloprimazine in depression. Importance of differentiation between each cause is in the management accordingly. Our treatment for this patient, starting FML 1/5, Labrican drop 1/6, Labrican gel 1/1, which have chelating agent inside it, and co-management with the rheumatologist to adjust or stop the treatment. Next slide will show the Pentacam before and after treatment. Here we will see the difference between before and after, as it's affecting the clarity and density in the Pentacam. You see the color map is different in both before and after. Also here the left eye. And detecting vortex keratopathy with Pentacam in 2 steps. At the location, anterior corneal layer appearance increasing value, which characterize like war-like pattern. Underlying cause, usually it's a drug lipid complex with epithelial cell scatter the light, and which lead to loss of transparency of Pentacam. In correlation with the rheumatologist, regular examination for early detection is important. Consider dosage adjustment or alternative therapy if symptoms worse. It's important to educate the patient about potential visual disturbance, monitoring and follow-up. Also monitoring the level of chloroquine, standard recommendation limit to minimize ocular toxicity, and also regular follow-up on ophthalmology and assessment post-diagnosis every 6 to 12 months. Next visit, 1 week apart, the cornea improved dramatically. The vascularization was thinner, and the position was better. Her visual acuity improved by 1 line. Foreign body sensation disappeared, and visual discomfort disappeared, and patient was feeling better. Her rheumatologist stopped the chloroquine and changed to hydroxychloroquine. Chloroquine and hydroxychloroquine timeline need to exacerbate from the body week to 2 months, sometimes take years. Reason because it have a long half-life, which take weeks to months and sometimes 2 years to eliminate slowly by renal. Her OCT as shown is normal. Our home message in this case is vortex keratopathy is an important consideration in SLE patient on chloroquine. Significant of early detection and monitoring, collaboration with rheumatologists and ophthalmologists is important to optimal patient care. Thank you.
It's a pleasure. It's a pleasure to have next speaker, Dr. Amir Mustafa. We're going to talk about 10 tips for successful DMAC.
بسم الله الرحمن الرحيم. أولا بشكر دكتور رانيا الخوجة على الدعوة الكريمة للمؤتمر. بشكر دكتور رانيا على الدعوة الكريمة لحضور المؤتمر. النهارده هنتكلم على some tips and tricks for successful DMAC. As we know, that DMAC is a lamellar endothelial keratoplasty that involves selective removal of diseased patients' descent membrane and endothelium, followed by transplantation of healthy donor corneal endothelium and descent membrane without any additional stromal tissue from the donor. Why DMAC? Because DMAC it provides a true anatomic replacement of a descent membrane and the endothelium. It provides us with minimally changes in refraction, rapid visual rehabilitation, less risk of immunologic graft rejection, no suture-related complications, intact globe so it will resist lead trauma, lesser risk of intraocular complications, triple procedure, more controlled, easier, and predictable visual outcome. The indications of endothelial keratoplasty, endothelial dystrophy like Fox endothelial dystrophy, posterior polymorphous corneal dystrophy, Chet syndrome, X-linked endothelial dystrophy, وIC syndrome. Acquired endothelial disorders like pseudophakic or aphakic bullous keratopathy, post-PK rejection, toxic anterior segment syndrome, post-inflammatory like herpetic endotheliitis, or post-trauma. Trick number one, the proper patient selection. No stromal scar. Avoid in your early cases the vitrectomized eyes. IOL should be in the bag. No large iris defects, so the air tamponade at the end of the surgery doesn't escape posterior. No peripheral anterior synechia. No glaucoma chance in the AC to prevent trauma to the DMAC graft. The DMAC graft preparation. You have to select a proper donor graft, and the most important point, the age of the donor. Intraocular surgery, not diabetic or hyperlipidemia, لأن ده بيزود الانسيدنس of retinal descent membrane tears during the preparation. Mark your graft before you start the surgery. In this technique, I stain the descent membrane with the endothelium up. I go for the periphery of the descent membrane just inside the trabecular meshwork and do an incision 360 degree. Then I stain again to highlight the edges of the descent membrane and the periphery, removal of the tags at the periphery. I dissect the descent membrane from the periphery to the central. في الخطوة دي لازم تكون الكورنيا كلها submerged by the fluid. I fold the graft upon itself. In between the two layers, I put an air bubble. Then drying the stromal side of the descent membrane and draw in it the F mark or S mark or any asymmetrical mark. So by this technique, I save the residual of the graft to use it in a dull case, and also you can take the F mark or S mark here. It's a simple technique. It doesn't require any special instruments. Rapid technique and preserve the stromal graft for the bulk surgery. Choose the proper graft size. The size of the graft must be carefully customized by measuring الوايت to white. قيس الوايت to white قبل ما تبدأ عشان تحدد من خلاله the size of the graft. The ideal size or regular size is 7.75 to 8 millimeters. We take a small graft in hyperopic eyes, shallow AC, Fox endothelial dystrophy because the pathology is mainly in the center. Large graft in myopic eyes, vitrectomized eyes, pseudophakic bullous keratopathy. The MAC graft injectors, we have different types of injectors like glass injection devices. ده أشهر واحد بتاع جويدر. والIOL cartridge. الفيديو لو سمحت. This is a glass الفيديو. شغل الفيديو لو سمحت. اللي بعديه ده. لو ما عندكش الجلاس انجكتور، ده هاند ميد انجكتور تقدر تعمله بالاي او ال كارتريدج. بشيل التب الاماميه وبوصلها باي في سات رابر. وبعد كده بنوصلها بالسيرنج 5 سي سي سيرنج. You can aspirate the graft through this tip. في حالة لو ما عندكش الجلاس انجكتور. ممكن برضو تستخدم الكارتريج او الانجكتور بتاع الكون. بعد كده obtain double scroll before injection. How to obtain double scroll ده بيفاسيليتيت unfolding. بعد كده aspirate from the wide opening of the injector. Inject and draw. Inject and draw. Inject and draw up to the desmet membrane will be unfold and take this orientation. This is unfolding a graft in the injector. When you inject in the AC, it will unfold more easily. في طريقة تانية نقدر نعمل بيها unfolding، نخلي الوان جرافت الوان رول إلى دبل رول. الفيديو ممكن بأي انسترومنتس بدخل جوه الفولد and the unfolding of the graft. I am away from the endothelium, so changing the behavior of the graft from one fold إلى to double fold or double scroll will make the unfolding in the AC more easily. Patient preparation. Marking the corneal surface. بناخد mark عليها 8 millimeters. This will guide desmet membrane strapping of the recipient cornea. Interrupted dot marks are used. This is always allows us to see the desmet membrane clearly between the marks. بتشيل الابيثيليوم الاول وبعد كده بناخد مارك على الكورنيال سيرفيس in this way. Dot marks بتفاسيليتيت الفيجواليزيشن of the graft during unfolding. برضو من ضمن السمول تراكس I do mark at the side ports to make the unfolding or shallowing of the AC during the surgery more easier and the visualization is more easier. Desmet membrane stripping or desmatorexis. The optimal desmet membrane should be well centered, atraumatic to the overlying stroma, no regular tags to decrease the incidence of desmet membrane detachment post-operatively. One of the track, I stain the desmet membrane before stripping, and this will facilitate the visualization because I strip the desmet membrane under Helon, not under air. Video. So staining of the desmet membrane before removal will enhance your visualization of the desmet membrane stripping and ensure that you removed all the desmet membrane and no residual tags. As you see that the desmet membrane takes the blue color, and this is make its visualization is more easier. So I stain before I start the surgery, and then injection of Helon and start the stripping of the desmet membrane or scoring of the desmet membrane. Staining again to highlight the residual tags. Constricting the pupil with myocol or manual stroking of the iris stroma. Then I do inferior peripheral iridotomy either to prevent the pupillary block, either preoperative by YAG laser or scratch down technique or anterior vitrectomy probe. This is the scratch down technique. Video. Do the inferior iridotomy inferiorly at 6 o'clock. It will prevent the post-operative pupillary block. If you don't have a probe for vitrectomy, you can go with a spatula under the iris And with any sharp instruments, you can scratch over the spatula and do peripheral iridotomy in case of no probe vitrectomy is available at this time. The MAC graft injection in the anterior chamber, you have to enter with the tip of the injector deep into the AC, make the bevel up after entering into the anterior chamber. The injector opening crosses the pupil. Use AC maintainer in your early cases. Remove the AC maintainer before removing of the injector. Make the AC shallow before going outside by injector to avoid ejection of the graft outside the wound. So, في الايد in my left hand انا شغل الفيديو لو سمحت في irrigation to maintain the anterior chamber. الفيديو go with the tip inside the wound, cross the pupil, and then make the bevel up and inject the graft so that the graft will be in the AC without ejection from the side, from the main incision. Then start unfolding. Graft unfolding before exiting الفيديو. Use the AC maintainer during the injection, and during the injection, then remove the AC maintainer to make the anterior chamber is shallow. You can notice that the fold takes the double fold techniques, and this will make the unfolding is more easier. Just removal of the AC maintainer, the graft will unfold more easier. Shallowing of the AC make the graft unfold. Then complete your unfolding. Also notice that the graft take the double scroll into the injector, then inject, then removal of the AC maintainer, and making the AC shallower will make the descent membrane will unfold more easier. The graft orientation unfolding with this is the incorrect orientation, and to the right is the correct orientation. Determining the graft orientation by Mitsuri sign, check the F or S mark, Bachmann sign, or intraoperative OCT. Video. After injecting the graft and starting to unfold the graft, do shallowing of the AC is the key point in the MAC surgery. Centration of the graft is very important. Then start to unfold the graft, and you have to check the orientation of the graft by F mark or S mark or by Mitsuri sign. You go with the cannula, as you notice that if it changes its color to the blue one, so the graft is in its correct orientation, what is called the Mitsuri sign. احيانا ممكن في تكنيك اللي هو بيستخدم الاير بابل. الفيديو الاير بابل. This is a small air bubble. I use it to unfold the graft, so it's a non-touch technique. I don't use the cannula. The air bubble will unfold the graft, especially in the vitrectomized eyes. If you have an inverted graft, you have to inject the fluid. بس أهم نقطة إن الانجكشن of fluid to be directed to the iris posteriorly, and the flow of the fluid will unfold the graft and it will invert the graft. الفيديو. So inject the fluid toward the iris, not toward the graft. And the current of the fluid will invert the graft. So, and then check with Mitsuri sign. Notice that the tip of the cannula will change its color from silver to the blue, so the graft, it's good orientation. At the end, tamponading of the graft by air injection or SF6 20% to support the graft. Using 20% SF6 has a longer time in the AC, and it provides longer time for the tissue to be supported. At the end, you inject with the tip of the cannula at the center, then start to inject in the center, not at the periphery, to avoid displacement of the graft. Start with a small bubble and then increase it gradually. One of my tricks, suturing of the side ports in complicated cases, it decreases the incidence of post-operative desmet membrane detachment. Post-operative position, it's very important to ask the patient to be a strict supine position for the first 24 hours. It supports the graft and prevents desmet membrane detachment. Thank you.
Dr. Usama Jledi, astigmatism correction in modern cataract surgery.
السلام عليكم. شكرا دكتور عناني على الدعوة والscientific committee. بالنسبة I'm going to talk about astigmatism in cataract surgery. So as you know, astigmatism prevalence is about 15 to 30% of our patients coming for cataract. They have astigmatism. And there's very strong correlation how much patients see 20/20 and how much the level of astigmatism. The more astigmatism we end after surgery, the patient cannot see 20/20, but also the quality, the patient happiness. If you ask a patient how many are happy after surgery, the more people had astigmatism, they are not the happiest ones. So it's very important to consider astigmatic correction when dealing with cataract surgery. Regarding traditionally, when we measure the K reading, we examine the anterior cornea only, but 15% of our patients, they have different posterior curvature, and then we miss the accurate total astigmatism. So nowadays, we need to check the anterior and the posterior corneal astigmatism, so we get us the total astigmatism, but that's what we need to do when we do cataract surgery, because we remove a cataract, so the total corneal astigmatism, that's what the patient will end with. So it's very important to check also the astigmatism, irregularity, and also you need to check the axis of astigmatism and multitude of astigmatism, like autorefraction, keratometry, biometry. Now we had also the anterior and posterior, and you always better to do topography, and that you measure the total astigmatism. But when you have too many measurements, it's good to have all the axes the same. If they have too many different axes, then this patient have regular astigmatism. You shouldn't consider treatment when you do cataract surgery. All patients really nowadays is better to do corneal topography. The reason for that, first of all, they check corneal regularity, check high order aberration, RMS, also looking for the total astigmatism, bachymetry, and also anyone who do premium cataract surgery, patient may need to have some refractive error. You may need to do laser top-up, so it's better to know, can I do top-up for this patient later on or not? Regarding there's too many machines available nowadays, we can check the total corneal astigmatism, either Schimflus device, most common is Pentacam, Galili, Series also, OCT device, also IonMaster, the 700, it gives you also the total corneal astigmatism, but is Avanti, MS39, Argus, all is very good machine, will give us the total astigmatism of cornea when you consider cataract surgery. How to correct the astigmatism when you do cataract surgery? Either we can do the surgery in the steep axis, and you do the incision exactly where is the steep K, or you could consider arcuate keratotomy or limb relax incision, either manually or using the laser. Then nowadays there's more trends to using IOL, toric IOL, but you could consider if someone had cataract surgery and still have astigmatism, you consider either do biggie bag or laser vision correction. Regarding the first option, astigmatic keratotomy, is very simple. We usually do the cut at the steepest axis, and usually we check the thickness of cornea, either using either ultrasound or OCT. Just very important to check it accurately. Remember, there's a coupling effect. If you flatten the steep axis, you steep the flat axis. So the spherical equivalent when you do arcuate is the same, so 0. So when you calculate intraocular implant, for example, biometry, just you look for spherical equivalent for that lens. Regarding is very simple, just you need to do the marking, and you need to fix the eyes, and just choose the depth you want to do. And usually always you need to do at the beginning of surgery because the eye is firm. Or before you do viscoelastic wash, because also the eye is fair, and that time it's easy to do the incision that time. Mammogram, there's too many mammogram available, and you need to look for the age factor and the axis and magnitude of astigmatism. But it's, what you can choose for the mammogram, you look for how much the diameter, the depth of the incision, the degree, how far is it, and it can be the angle, is it vertical or oblique, and usually this is with the femto laser, you can choose the angle better. Remember that our patient as itself, we always prefer with the rule astigmatism. So if you have a patient with the rule astigmatism, aim it to keep it low or minimum, but not overcorrected. Against the rule astigmatism, aim it to full correction of astigmatism, but always avoid to flip the astigmatism because the patient not happy if you flip the astigmatism. It's very simple when you do it under the arcuate keratotomy. It's cheap. You could customize at the surgery. Even after the surgery, post-op, you could do it under slit lamp. So you can tune it. Disadvantage because you do the cuts, so the predictability of healing is not as predictable. You could perforate and you have to stitch the patient. Patient usually have some discomfort. You have a limited access how much you corrected with the cuts. You could induce regular astigmatism, also can induce dry eye and infection. As I mentioned, there's too many mammogram. It's available, and you can choose whatever comfortable for you. You can also use the application. You can use the online application. There's different lenses they can give you. Johnson & Johnson, they have different one. Or there's in the smartphone application, you can use it to calculate the cuts. If you had femto laser, it's very precise arcuate keratotomy, but it's very expensive. It had very good centration. I usually use it for corneal graft, but not for cataract really. But some people, if you do femtocataract, you can do it in you can do the arcuate keratotomy the same setting when you do the cataract surgery with the femto laser assisted. Nowadays, there's trends to do implants because it's a very powerful way to correct astigmatism. So there's more you can do it for monofocal or multifocal. But the very important, the key for the treatment success of toric implant really to choose the axis power, the alignment of the axis, and also to prevent the rotation, because if the lens rotates, it will have less effect. And the different machines, company provide you with different calculators. So iMaster 700, they give you the calculator, but if you're using any Zeiss lens, for example, they have this calculator. Alcon, they have their website calculator to tell you the alignment of the lens you need to implant it. For the marker, it's very important to have the axis aligned exactly, and there's different way how you can align or mark the axis. The commonest one is manual, but we could use digital image or femtosecond laser. When we do cataract, we can do touching the anterior capsule as a marker. Manual marker is there's too many also available in the market. Personally, I really prefer the simple one, just the slit lamp, put it horizontal and put the marker where the patient sits in position, but you can have many tools available to do digital manual marker. Digital image, if you had access to the microscope like Zeiss, Galaxy, iTracy, Varian, all is very good way to do digital marker, or if you are lucky, you had post-operative aura decor, which is very expensive, not common use, but that you can do it when you finish the cataract surgery. You can do aura, you can even measure the astigmatism after you implant the patient. This is one of our patients, the Callisto Zeiss. It's a very good, powerful way to align. Even this patient had a bit of corneal conjunctival edema. It's still you could able to register the eye and align the lens during the surgery. Remember, the toric implant, if it's rotated, will have less effect. So any 1 degree of rotation, you lose 3%. So if someone had like 3 diopter astigmatism, if 10 degree diopter rotation, we lose 1. So 10 degree rotation, reduce the effect by 1/3. So it's very important to have right alignment. One thing is important when you do cataract surgery with toric implant, you need to prevent the rotation. So how to prevent the rotation? One of them is to choose the right design of implants, so that there's different implant can be more stable in the backs. You need to do the capsular access smaller than the optic of the lens. Always very important to wash the viscoelastic, especially behind the lens. I sometimes use mitotic to make the pupil smaller to reduce the rotation, and some people advise the patient to rest for the first hours because the rotation usually happens the first hours after the surgery. But if the patient had surgery and still have astigmatism or come to you from different place and you don't know the lens rotated, you could use what you call website astigmatism fix. And nowadays there's eye tracing machine which can measure the astigmatism and tell you exactly how much you rotated. I'm not sure that's the screens. I think we run out of time maybe for today. Can I have the slide again?
شكرا دكتور أسامة. نظرا لضيق الوقت نرجو الالتزام بالوقت المحدد لكل محاضرة. طبعا السيشن الريتينا حينقسم إلى جزئين، جزء قبل الصلاة وجزء بعد الصلاة، فاحنا نضطر آسفين أن نلتزموا بالوقت المحدد وإلا سيتم إغلاق الشاشات.
Did I use 10 minutes? I didn't use 10 minutes by the way. ما استعملتش 10 دقائق، أنا متأكد من الوقت بتاعي.
أوكي تمام.
على كل حال شكرا، بارك الله فيكم.
Next speaker, دكتورة ولاء. Dr. Wala will talk us about reviving the graft.
Okay, Assalamu alaikum. Today we'll talk about reviving the graft in the case of the neck. Okay. This lady is diabetic since 2002. She had a history of complicated left eye phaco and IOL implant 5 months back. When she came, her vision was 0.1 and left hand movement, IOB was normal, right eye anterior segment was okay. She had a diabetic maculopathy, the left eye pseudophakic bullous keratopathy, AC normal, pupil irregular, and IOL in place. On the second day of this year, she had a left eye demic done in our hospital after 2 hours. Sorry. Okay. The graft is in place, S sign seen, inferior eye okay, the tension is acceptable. The second day post-op, she had a positive purulent conjunctival discharge, culture obtained from it, and the result shows staph epidermis. So we decreased the Bradford drops frequency and added fortified vancomycin and vigamoxide drops. First week post-op, the patient had positive epithelial defect, and OCT anterior shows the graft in position. After 20 days on treatment, there is no improvement. The eye is still congested, watery, but patient is in discomfort, persistent epithelial defect, clear, and hazy cornea. The anterior segment OCT shows detached graft as shown here. We changed the treatment. We added fortified vanco drops 1/4, fortified gentamicin 1/4. We tapered more Bradford to 1/2. A month later, patient more comfortable now, less congested, no more epithelial defects, so we decide to interfere and inject air in the IC. First air injection, unfortunately the air was not adequate, the flap still detached. The second air injection shows the flap is adequately attached. 1 month later of air injection. Thank you. Sorry for that. This is 1 month later. The graft is attached well. The cornea is clear. The vision is better. Point 2. I want to stay in that early infection and persistent epithelial defect, even with the delay graft adherence with adequate antibiotic and adjusted steroid dose, we can successfully reattach a functional graft and restore corneal clarity. Thank you.
Now, as we transition into the surgical retina session, we would like to invite our esteemed moderators to the stage. Please welcome Dr. Ashraf Al-Sha'rawi, Dr. Gharib Al-Shara, Dr. Khalifa Aswedi, Dr. Muhammad Tawfiq, and Dr. Juma Al-Umrani. Please come up.
Bismillah ar-Rahman ar-Rahim. It's our pleasure to start now our surgical retina session. And I would like to introduce the first presentation, which will be with my dear colleague, Dr. Samir Al-Baha. He was going to speak about managing difficulties in diabetic vitrectomy. And I urge all the speakers to stick to the time, including myself.
السلام عليكم. الحقيقة بحب أشكر الأورجنايزنج كوميتي وعلى رأسهم الدكتورة رانيا الخوجة والدكتورة ناهد. I'm going to talk about diabetic retinopathy. As we know, proliferative diabetic retinopathy, the main gold standard عندنا اللي هو PRP اللي هو laser photocoagulation. Intravitreal anti-VEGF ده don't reduce retinal ischemia. And the disease will recur when injection stops. في new vessels أنا هحقن في الدنيا ماشية كويس، مجرد stop injection هيحصل الديزيز يرجع تاني. There is risk of fibrovascular contraction ممكن يحصل وده بنسميه Crouch syndrome، وممكن يحصل vitreous hemorrhage ويحصل traction detachment. عايزين نتكلم على الانجيوفايبروتيك سويتش. عندنا الفيجاف اللي هو اي ممبرين بيكون من حاجتين، في فاسكولار اندوثيليال جروث فاكتور وفي عندنا كونكتيف تيشو جروث فاكتور. اي واحد فيهم هيتفوق على الثاني هيعمل مشكله. لو الكونكتيف تيشو جروث فاكتور زاد ده هيؤدي الى بروجريسيف فايبروزس. دي حاله قبل الانجكشن زي ما احنا شايفين الممبرينز قليله ومش باينه. بعد الانجكشن طبعا في اكستنسيف ممبرينز شايفينها. بالنسبه للنون كليرنج فيتريس هيموريج، لو احنا عندنا فيتريس هيموريج وفيتريس هيموريج doesn't resolve، في حاجه مهمه جدا، هل العيان ده اخذ PRP قبل كده؟ هل اتعمل له انجكشن؟ لو ما اتعملش معنى كده العيان should be vitrectomized. لكن لو العيان treated before واتعمل له PRP ده يعتبر inactive proliferative retinopathy، والهيموريج از لايكلي نتيجه ان حصل فيتريستراكشن وشد على النيو فيسلز وعمل لي البليدنج اللي موجود ده. وهنا ممكن we can wait to follow the patient by ultrasonography. لو جينا اتكلمنا عن الانسترومنتيشن مهم جدا يكون معاك فورسبس، كيرفد سيزور، شاندلير از نوت ان اوبشن، مانداتوري دلوقتي في كل الحالات، اكتيف اسبريشن اند كيرفد ليزر. There are different techniques، في تكنيكس كتير جدا، وتملي في مقوله بنقول عندنا في مصر ان هو اللي تغلب بيه العب بيه، الحاجه اللي انت بتعمل لها بيرفكشن جو اهيد، الحاجه اللي بتماستر جو اهيد، ما تحاولش ان انت يعني تستعرض يعني. طبعا الفيرست تكنيك وون اوف ذا اولدست تكنيك اللي احنا بنشوفها اللي هو البيلينج بتاع الممبرين زي ما احنا شايفين، والبيلينج لازم يبقى تانجنشال ان احنا بنخليه تانجنشال بالمنظر ده. طبعا الممبرين سيجمنتيشن وان اوف ذا اولدست تكنيك برضو، ان احنا مش قادرين نشيل الممبرين كله نتيجه ان في اتاتشمنتس كتير. طب احنا واي نوت ان احنا نقطعه زي البيتزا كده ونخلي بس حتت صغيره تبقى موجوده زي الفيديو ده زي ما احنا شايفين، ابريتينال ممبرينز واكستنسيف. وزي ما احنا شايفين مش لازم نشيل الممبرين كله، مش شطاره ان انا انظف الشبكيه تماما واشيل كل حاجه، لا انا ممكن اسيب سيجمنتس بالمنظر ده كده. These parts will not damage او هتعمل لنا مشكله او هتسبب اي مشكله. الفيسكو دايسكشن another تكنيك، ان انا بجيب انجكشن اوف هيلون، والهيلون ده بحقنه بين الممبرين والريتنا، وبعد كده بخش بسيزور بشيل الممبرين ده. برضو من ضمن التكنيكس المشهوره جدا اللي هو الديلامينيشن، في different scissors straight horizontal vertical and curved. هو يمكن الاثنين الكومن بيستخدم الفيرتيكال، مشكله الكيرفت لما تحرك البليدز دي بتموف اب اند داون، دي ممكن تعمل تروما للريتنا. لكن الكيرفت احسن، والكيرفت ده بيبقى واخد كيرفتشر معين اللي هو 135. طيب انا ممكن اخلص كل الممبرين بالكتر، انا مش لازم ان انا استخدم كل حاجه، لا طالما انا قادر ان انا اخلص الممبرين بالكتر اتس سو ايزي. انا بستخدم فاكيوم في الاول، وبعد كده بعد الفاكيوم برفع الممبرين من على السيرفيس اوف ذا ريتنا، بعد كده اشغل كاتنج، لازم نكلك على الفوت سويتش فاكيوم وكاتنج اون اند اوف على طول. زي ما احنا شايفين ده فولد باك تكنيك هنقوله بعد كده. طيب عشان الوقت بس احنا في عندنا كاتر ديليمينيشن. ستيف تشارلز عمل تو تكنيكس اللي هو الفولد باك تكنيك، ان انا بسحب الممبرين عليا يعني زي بالظبط كاربت او سجاده بسحبها عليا. ده one of the safest تكنيك انا ممكن استخدمه واشيل كل الممبرينز من غير ما اعمل تروما. It is the safest technique، بيدينا سيفتي عاليه جدا ما يعملش اي تروما to the retina. وفي التكنيك الثاني اللي هو conformal delamination، ان انا بخش وببتدي اكل في الممبرين كده زي يعني فورورد، وطبعا ده في ريسك عالي جدا انه ممكن يسبب تروما تو ذا ريتنا. بس في تريك لازم نعملها، ان انا بشيل الممبرين واعمل فاكيوم وارفع وبعدين كاتنج، اخش بعد كده برفع الممبرين واعمل كاتنج، ما اخشش على طول كاتنج لان كده انا ممكن اتروماتايز الريتنا. في تكنيك لطيف جدا برضو من الحاجات اللي هي يوزنج كاتر وسيزور. بس الكاتر انا بستخدمه كفاكيوم، فاكيوم يعني انا بعمل الفاكيوم ما فيش كاتنج وابتدي اسحب الممبرين فوق، وبعد كده بالسيزور اخش ممكن استخدمه كبلانت لو هو مقفول، ممكن كشارب كسكينه بالظبط، او ممكن استخدمه كسيزور زي ما شايفين فاكيوم وكاتنج، وبعد ما بخلص الحته ببتدي اعمل اشيل الممبرين تماما. اوكي، الباي مانيوال تكنيك طبعا one of the commonest technique عملها ماكيون سنه 84، ان انا بستخدم تو انسترومنتس. طبعا الشاندلير از مانداتوري، وزي ما احنا شايفين ان انا بمسك بالفورسبس وابتدي بقطع بالسيزور لغايه لما اشيل الممبرين. انا مش عايز اطول عشان الوقت. انا هعرض اخر تكنيك اللي هو تراي مانيوال تكنيك. التراي مانيوال تكنيك ده الحقيقه I invented this technique الحقيقه، وسميته تراي مانيوال عشان انا بستخدم 3 حاجات طبعا، منهم بيفلوروكاربون وفيتريس وسيزور. زي ما احنا شايفين الباي مانيوال ده احنا بنستخدم، ممكن يسبب بريك، ممكن يسبب هيموريج زي ما احنا شايفين، ممكن يسبب حاجات كتير. طيب التراي مانيوال ده انا عندي ممبرين فاسكولارايز، ممبرين مرعب على الريتنا. طب انا عايز اشيله من غير ما اسبب اي حاجه. سهل جدا ان انت بتبتدي تحقن بيرفلور بعد ما تعمل كورفيتراكتومي، ننجكت بيرفلوروكاربون، والبيرفلوروكاربون ده يوصل لغايه الاكويتور. وممكن اعمل ستيننج I need 30 seconds بس. وببتدي اعمل ستيننج ممكن بتريبان بلو عشان استين الممبرين عشان ابقى شايفه كويس. بعد كده بالفورسبس ابتدي ارفع الممبرين زي ما احنا شايفين، وكات باي سيزور. طبعا ميزه التكنيك ده ان انا البيرفلوروكاربون بوش ذا ريتنا وبيبوش الممبرين، ما بيخلوش يرجع تاني، لا هو بيتقلب ويبقى بالمنظر ده كده. وابتدي بسيزور اقطع الايبي سنترز واحده ورا الثانيه. هيموريج اقل ما يكون، مينيمم هيموريج. الهيتروجينيك بريك مينيمم هيتروجينيك بريك. يعني الحقيقه دي ده السيفست تكنيك احنا ممكن نستخدمه. زي ما احنا شايفين we removed almost most of the membrane زي ما احنا شايفين لغايه لما وصلت المرحله دي الاوبتيك ديسك. زي ما احنا شايفين نو بريكس. احنا العيان ده يو دونت مش محتاج ان انت تعمل سيليكون ولا ايه، العيان ده سيبته على فلويد ويت باس فيري ويل. ثانك يو فور يور اتنشن.
Samir, for this nice presentation and for sticking to the time. Our next presenter is the Professor Mohsen Abu Shusha. Is going to talk about oil in combined diabetic vitrectomy. We will delay the discussion till the end. So if you have questions, just collect it. We will discuss it in the end.
Ar-Rahman Ar-Rahim. Thank you for having me in this prestigious meeting. I would like to thank all the organizing committee for inviting me. Today I'm talking about the IOL implantation in cases of combined phaco-vitrectomy. Vitrectomy is considered to be an essential surgical approach for the management of advanced complications in diabetic eyes. And when we consider the crystalline lens, there is a high rate of progression of cataract in vitrectomized eyes. And also there is a high percent of eyes that already have some degree of lens opacities before vitrectomy. Also, we should consider that the pseudophakic state allows for more radical vitrectomy and more easy and complete vitreous base shaving. So, combined phaco-vitrectomy seems to be an attractive option in those diabetic eyes. However, combined phaco-vitrectomy is reported in many studies to carry a higher risk for iris posterior synecdoche, increased intraocular pressure, increased neovascularization, and neovascular glaucoma. And in these cases, we may need YAG iridotomies, which fails in many times. And we may also need surgical iridectomy or surgical synecholysis in those cases. So how to solve this problem? I adopted for many years to do a prophylactic iridectomy, surgical iridectomy, when I am doing combined phaco-vitrectomy in diabetic cases. However, when we revise those cases, we will notice that the synechia occur between the remnant of the anterior capsule and the back of the iris. So if we succeeded to separate these two structures by putting the IOL in the sulcus, we will succeed to prevent this synechia. So by putting the IOL in the sulcus, we prevent the synechia between the back of the iris and the remnant of the anterior capsule. And this is my idea. This is a routine phaco before vitrectomy, and after finishing all the stuffs of the crystalline lens and doing irrigation aspiration, we inject the viscoelastic or OVD, opening the sulcus and putting 3-piece IOL in the sulcus, as you can see. So we are aiming to get rid of the synechia by preventing the synechia between the remnant of the anterior capsule and the back of the iris. Another case, again, this is the 3-piece IOL in the sulcus. I adopted to take a sutures to stabilize the anterior segment during vitrectomy, and I will start my vitrectomy by first doing posterior capsulotomy and then going to complete my vitrectomy. And this is a third case, the same technique after phaco, after regular phaco, just putting the 3-piece IOL in the sulcus. And this is the post-operative photos. As you can see, there is no single posterior synechia, a very beautiful centralized IOL with a good red reflex and no increase in the intraocular pressure and no synechia. We have a study of about 117 eyes of 73 patients, and this is the demographic data of the patient. As we can see, we divided the cases into two groups. Group 1 with the new technique by putting the 3-piece IOL in the sulcus, and group 2 regular 1-piece IOL in the bag. And there is no difference between the two groups statistically preoperatively. And this is the indication for vitrectomy in the two groups. Also, there was no statistical significant difference between the two groups. And this is the post-operative. Regarding group 1 with the 3-piece IOL, they had a better, best corrected visual acuity at the end of the study. And they have, this is the visual acuity difference between the two groups. And also they have a better control of intraocular pressure with less use of anti-glaucoma drugs. Excuse me, there is a delay. And there is less use of anti-glaucoma drugs in those patients using the 3-piece IOL. Also, we did not find any posterior synechia when we are using 3-piece IOL in the sulcus in those cases. And of course, we did not use any YAG laser or surgical iridotomies in those cases, on the contrary to the second group when we are using a lot of YAG laser iridotomy or surgical iridotomy. To take home message, 3-piece sulcus hydrophobic IOL in cases of diabetic phaco-vitrectomy is associated with significantly better post-operative best corrected visual acuity, significantly lower incidence of posterior synechia, and better control of intraocular pressure in post-operative period. less need for anti-glaucoma medications, and less incidence of rubiosis iridis compared to one-piece hydrophobic in the bag IOL. And thank you.
For nice presentation. Next speaker, Professor Ashraf Sharawi, Professor of Alexandria Forestry, will talk about chandelier assisted buckle back to the future.
Bismillah ar-Rahman ar-Rahim. It's my pleasure this morning to be here in Libya, in Trablos, my beloved second country, and I would like to extend my thanks for the organizing committee to allow me to present in this prestigious meeting. My talk today is about chandelier-assisted buckling back to the future. Retinal detachment had passed through many histories from the last decade, and we remember that James Wayne was the first to describe the retinal detachment. Von Grave modified the management by puncturing the retina and draining the subretinal fluid into the vitreous cavity. And if we talk about sclera buckling procedure, which is the conventional method of treating of retinal detachment, we apply a pressure or stress or inward indentation to buckle or the formation of the structure. Its purpose to close the retinal break so that the subretinal fluid is absorbed and the retina is attached. We has to give the credit to Gonen, who had invented the ignipuncture of the retinal breaks through applying of heat to the surface of sclera to close the retinal breaks. And the father of the modern retinal surgery, which is Skippens, who had invented the indirect retinal ophthalmoscope. So what we have today in these treatments, we have either scleral buckling procedure, pneumatic retinoplexy, pars plana vitrectomy, with or without sclera buckling. As we all know, the pseudophakic retinal detachment, which is a special category of retinal detachment, most people would go for vitrectomy, pars plana vitrectomy, because it's much easier. You have a clear lens, you don't destroy the lens. It's characterized by multiple small flap tears at the periphery of the retina, which is sometimes very difficult to visualize in the presence of opacities of the posterior capsule. And it's characterized also by more macular involvement and more tendency for PVR. There came a new technology. We had revived the buckling procedure, which is a combined use of WAV, or wide-angle viewing system, and chandelier twin light. There are more advantages over traditional methods: clear direct retinal image, easier detection of retinal breaks, ease operation for the surgeon. وبالذات whenever you get old and your back tries to hurt you, if you are going with the conventional methods, you will quit it after time and go for vitrectomy. However, the use of chandelier had eased our procedure, like this case with upper temporal retinal detachment. And as you can see clearly the retinal details. You can see and find the small flap tears at the vitreous base in pseudophakic retinal detachment. You apply your cryo externally, you drain subretinal fluid, you place your buckles, and at the end of the procedure, you can see clearly that the break is well supported, the retina is reattached, and you cannot miss any retinal break. And this is the post-operative appearance. Again, another case with the supratemporal retinal detachment, and in this case in particular, it was recurrent, And in spite of the fact that it was recurrent after buckling procedure, examination showed an upper horseshoe break at 12 o'clock, in which cryo was applied, drainage of the subretinal fluid, and the retina is completely attached. Again, upper nasal flap tear, you localize your break, apply cryo, drain the subretinal fluid, and in this case, so easily, you apply a radial sponge and not even a buckle, and you get the retina attached, as you can see in this post-operative appearance. Another entity of retinal attachment in which you get inferior retinal breaks. These are very hard to support using vitrectomy techniques because either gas or silicone does not support this area. And as you can see, cryo to the area, drainage of the subretinal fluid, and this is the post-operative appearance, complete reattachment and buckling of the peripheral retina and the break, and this result is very stable for life. Again, infratemporal retinal break, just a radial buckle and the retina is attached. Another supratemporal retinal detachment, you apply your cryo, drain the subretinal fluid, and you be sure that the break is supported by the buckle. Inferior bullous retinal detachment, and in this case, you have to know that the retinal break is usually above the horizontal line, although the detachment is inferiorly. However, there are some complications, including submacular hemorrhage during the drainage, and which disappears after some times. Sometimes the sutures are intruded inside the vitreous cavity after some years, and as you can see, the Dacron suture is inside the vitreous cavity. Myopic shift due to high buckle, retinal incarceration. However, you can see it very clearly during the drainage procedure, and just by shifting your buckling element to the area of the incarceration, you save the patient from other problems in the future. Choroidal hemorrhage during placement of the suture. As you can see, this is an upper temporal retinal detachment, and you apply the cryo, drain the place the encircling element. While passing the suture, you had created a superficial choroidal hemorrhage because you passed so deeply in the retinal, in the scleral fibers. Post-operative, you can see that the hemorrhage is there infranasally. However, 6 months later, the retina is still attached with the hemorrhage disappeared. PVR, as in this case, in which we had applied chandelier buckling primary for the patient, drained the subretinal fluid, the retina is attached. However, it stayed attached for 2 months. 2 months later, it came like this, severe PVR grade G1. You have to go for surgery, try to remove all the epiretinal membranes and the subretinal membranes. And finally, at the end of the surgery, you are able to reattach the retina in the post-operative appearance, as you see in the OST with the macula attached. And there was some proliferation inferiorly. 2 months later, reproliferation inferiorly, and the fibrosis and the detachment was approaching the macular area, and you have to go because the patient is siliconized to remove the cataract, and to go and to do retinectomy. There is no other way. As you can see, there is extensive subretinal, intraretinal. Just give me 1 minute. Just 1 minute, please. And you have to go to retinectomy to remove all this fibrous tissue. In spite of your trial to remove the retinal tissue, there was some intraretinal, subretinal fibrosis in the form of a plaque, which was very difficult to remove. But I decided finally to leave it because I have to remove the retina very close to the optic disc. And this is the post-operative, the macula is again reattached. However, after 2 months again, there was some fibrosis and retinal detachment inferiorly. However, since the macula was attached with a visual acuity of 260, I decided not to approach this patient. The take-home message is that chandeliers causes a technique with clear, direct retinal image, easier detection of small retinal breaks, wider angle of viewing, better illumination, ease of the operation for the surgeon and his back and neck muscles. This is very important. And it's a very good teaching tools because previously we were not seeing what's going on using the indirect, either you or the assistant. I would like to invite you all to attend the next bridge meeting in next May 2026. Thank you.
نظرا لاقتراب موعد توقيت صلاة الجمعة فحنعطي بريك لمدة ساعة عشان الإخوة يجهزوا نفسهم للصلاة وحنرجع بعد ساعة تقريبا. المسجد فيه مسجد قريب مقابل الطريق من الجهة الثانية فتبوا جهزوا نفسكم أي واحد يمشي غادي ولكن بعد ساعة إن شاء الله نرجع بإذن الله.